handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose violation of RA 8293. Violation of RA.
Follower has been having dark colored stools next to the vomiting greenish output, has OA of both knees with takes naproxen almost daily, drinks alcohol every day. On DRE, you saw black tarry stools per examining finger, and in the labs is microcytic hypochromic anemia. So what's a likely diagnosis? So actually, clinical presentation pa lang, we can already tell that it's clearly a case of UGIB or upper GI bleeding because of the description of black tarry stools, meaning pag may the patient kasi present with black tarry stools, it means that the blood has been present in the GI tract for more than 14 hours, as you will see next in the next slide. No? So ano ba yung description ng black tarry stools? So pag sinabi black tarry stool, so sobrang black niya. And actually may iba siyang amoy, no? Madi-differentiate mo siya sa amoy ng normal na stools. And yung amoy niya is malansa na sumisimoy talaga sa buong kwarto. Okay, so iba talaga siya, no? Pag hindi ko masyadong describe, pero pag naamoy yun siya sa wards, pag nag-duty na kayo, hindi makakalimutan ko ano. Isa pa technique na pwede yung gawin, may mga dark green kasi, no? Black siya from the outside, Pero pag ano na, pag in-spread out niyo yung dumi dun sa diaper, dun pala dark green lang talaga or dark yellow. So ang gagawin niyo, pwede niyo gawin, so yung black na yun, pwede niyo i-spread out siya dun sa diaper, and then pag black pa din siya, most likely black tarry stools talaga siya or melena talaga. So, may mga dark green kasi, hindi yun melena. Okay, so dark green stools lang siya. And, wala pang ibang clues dito sa patient natin na most likely may UGIB. Nagtitake siya naproxen almost daily, so NSAID siya, diba? So, NSAID kasi is one of the major risk factors for na magkaroon ng patient ng UGIB from PUD or peptic ulcer disease, no? Drinks alcohol every day, so alcohol, isa pa yan, na risk factor for having PUD or even erosions lang, no? And then sa labs, makikita mo, microcytic hypochromic anemia, indicative of chronic blood loss and iron deficiency anemia, no? So, talagang, dyan pala makikita mo na may UGIB siya, and long-standing yon and may risk factor din. So, sabihin, mukhang may PUD siya from UGIB siya, upper GI bleeding from peptic ulcer disease. So we can surmise from the character of the GI bleeding, the possible location of the GI bleeding, no? Meron tayong dalawang klase ng GI bleeding, could be overt or occult. Overt means obvious, occult, edi ano lang, acromic blood loss na minimal lang, hindi everyday nagpapakita, no? So sa overt bleeding, it can be hematemesis or coffee grounds vomitus, may black yung from the acid, yung blood pag nag-interact sa acid na nasa stomach, pwedeng maging coffee grounds yung vomitus na makikita sa NGT or isusuka niya mismo. Or it can also be red blood, no? It usually indicates pag hematemesis that the bleeding is from an upper GI source. Pag melena naman, described as black tarry stools, it means the blood has been present for more than 14 hours in the GI tract, for as long as 35 days. No? Usually means a more proximal source. Pag hematochezia, meaning blood in the stools, ito kasi blood in the vomitus, yung hematemesis, no? Yung hematochezia is blood in the stools, no? Usually represents lower GI source naman. Pag occult bleeding, symptoms of blood loss na makikita mo or anemia, for example, dahil sa the chronic blood loss niya, dahil ng occult bleeding, leading to IDA or iron deficiency anemia, could lead to lightheadedness, syncope, angina, or even dyspnea from reduced na delivery of oxygen to the myocardium, no? Kaya kakaroon ng pwedeng dyspnea, and then positive din yung fecal occult blood test or FOBT. Now, yung site of bleeding could be upper or lower GI bleed. Pag sinabing upper GI bleed is the esophagus, stomach, and the duodenum. Pag lower GI bleed, it's below the duodenum hanggang colon. Okay? So, meron din small intestinal and then obscure or occult bleeding. No? Hematochezia, no, tandaan nyo, pwedeng magkaroon ng hematochezia is usually from a lower GI source. Yung hematochezia can also represent bleeding from an upper GI source. Hindi ang lower GI source, it can also represent bleeding from an upper GI source, lalo na pag sobrang dami ng upper GI bleeding, na wala na siyang 14 hours to wait para maging melena siya. Yung bleeding from the upper GI source, sobrang dami, na-evacuate agad, nakarating agad ng colon, na idumi niya agad, so naging hematochezia. Upper GI source na hematochezia, massive bleeding yung sabihin. It will present with hemodynamic instability usually kasi sobrang massive ng bleeding. Okay? So paano ma-differentiate yung upper from lower GI bleeding? Sabi ko nga, esophagus, stomach, and duodenum. So stomach, esophagus, stomach, and then duodenum. First part, second part of the duodenum, third part, and then fourth part of the duodenum. After the duodenum is the ligament of Treitz. Ito yun, no? Ligament of Treitz. Ito yung nagsasabi or yung border between the upper GI and the lower GI. Kasi after the ligament of Treitz, tinatawag natin na lower GI. Okay? So, upper GI bleeding, meron tayong iba't ibang causes. Pwedeng peptic ulcers, variceal bleeding, erosions, Mallory-Weiss tears. No? Pero, the most common cause, dun sa apat na sinabi ko, is peptic ulcers. That's the most common cause of upper GI bleeding. And endoscopic features dictate prognosis and management. It accounts for half of upper GI bleeding, hospitalizations in peptic ulcers. Meron tayong tinatawag na, I will show you, no? Meron tayong tinatawag na Forest classification, FORREST, Forest classification. It ginagamit siya in the description of endoscopic na features ng peptic ulcers, as you can see here. And this will dictate kung need ba natin ng endoscopic treatment, like lalagyan ba natin ng glue or clips to seal the bleeding, or just medical management. So either endoscopic management with medical management or medical management na talaga. So depende sa kung ano yung pinapakita sa Forest classification. So pag more severe, like itong active spurting na to, pag more severe yan, kailangan niya ng glue or ng clips to seal the bleeding para magtigil. Pero pag yung mga ganito lang, clean ulcer or flat pigmented spot, hindi na kailangan niya ng clips. Pwedeng medical management in the form of PPIs, pantoprazole, meprazole, ganyan. So, kung mas active yung bleeding, or active spurting, or oozing, or visible vessel, mas increase yung rebleeding risk. So kahit yung gamot ka, pwedeng mag-bleed siya. As opposed to clean-based ulcer, less likely yan mag-bleed. Okay? So, ano yung ginagamit natin pag mag-treat tayo? So, we can do endoscopic therapy. Pag adherent clot, depende, no? Pwedeng meron, plus minus endoscopic therapy lang. Pero kung visible vessel oozing or active spurting, endoscopic therapy talaga kailangan yan. Pwedeng in the form of electrocoagulation, heater probe, or injection therapy. Injection therapy is in the form of alcohol epinephrine para mag-narrow yung vessel and then hindi na siya mag-bleed. Or clips, no? And then, yung adherent clot, visible vessel oozing and active spurting ng mga Forest classification ng peptic ulcer, ay kailangan lahat yan ng intensive PPI therapy. Intensive PPI therapy is defined as IV bolus of that PPI, pwedeng omeprazole, pantoprazole, 80 mg sa bolus, followed by 8 mg per hour infusion times DDs. Kaya nakikita nyo yung mga residents, so pag nag-order sila sa mga patients na may UGIB, nakikita nyo, omeprazole, 80 mg IV now, and then makikita nyo in-incorporate nila yung omeprazole sa isang omeprazole drip times 72 hours, kaya 3 days, no? Kasi 3 days yung intensity PI therapy, no? Pwedeng omep drip siya or omeprazole drip, pwede rin na intermittent high doses. For example, imbes na omeprazole drip times 72 hours, pwede nilang gawin na intermittent high doses, pwedeng 40 or 80 milligrams Q12, no? Pwede yun. For 3 days, 72 hours din yung intermittent. Actually, wala naman silang difference no, based sa studies. And then, PPI twice, pagkatapos ng day 3, pagkatapos ng day 3, which means day 4 hanggang day 14, na yung patient ay nagkaugib, bibigyan mo pa siya ng PPI twice daily, BID. So, pwedeng drip, then Q12, then win mo BID from day 4 to 14. And then, after ng day 14 sa day 15 onwards, pwedeng PPI once daily na lang. Pero kung yan ay flat pigmented spot lang or clean based ulcer based sa forest classification, oral PPI therapy lang kailangan. So, bakit natin kailangan ng high dose PPI? Pag sinabing high dose PPI is 80 milligrams of bolus and then drip or high doses na 80 milligrams Q12, bakit natin kailangan? Kasi kailangan natin i-sustain yung intragastric pH to more than 6. Dapat more than 6 yung gastric pH natin in order to stabilize the clot para hindi na mag-bleed ulit yung peptic ulcer. And pag maintain natin yung pH na more than 6 and dahil sa administration natin ng high dose PPI, it decreases the rebleeding risk and also decreases mortality. Okay? So, hindi lahat i-admit mo, no? So, pag ganito yung classification, on based on force classification, active spreading, using visible person, adherent, sila yung mga patients na kailangan mo i-admit. Pero kung clean based ulcer, pwedeng i-discharge mo na agad. Okay, I will show you later, no? Makikita natin na may magandang algorithm later. Pakita ko sa inyo. So, peptic ulcers, most patients will rebleed in the following years if no preventive strategies are employed. So, ito yung mga kailangan nating i-prevent, no? Kailangan natin i-prevent na yung patient is magkaroon ng infection with H. pylori kasi H. pylori yung organism na associated with the development of PUD, peptic ulcer disease, and also the use of NSAIDs or acids, no? Pag in-eradicate natin yung H. pylori, actually brings down the rebleeding risk to less than 5%. So, sobrang effective, no? Pag in-eradicate natin yung H. pylori, NSAIDs should also be stopped when bleeding ulcer develops. Pero, kung kailangan talaga natin ng NSAIDs in patients na nag-ugib, kailangan natin silang i-have to give the NSAID with a COX-2 selective NSAID. So, instead of NSAID na ibigay mo, kailangan ibigay mo COX-2 selective. For example, yung Celecox, hindi yan COX-2 selective yan, diba? Tapos yung COX-2 selective na nadagdagan mo pa ng PPI para hindi na siya mag-bleed, okay? So, yung second cause, most common cause ng ugib is esophageal varices, no? So, ito, poorer yung outcome niya kaysa sa PUD na pag-esophageal varices. Kasi yung patients kasi nagkaroon ng esophageal varices, yung mga patients may liver cirrhosis. So, syempre, the liver cirrhosis itself, sama mo na yung esophageal varices, talaga mas pangit yung kanilang prognosis, no? As opposed sa mga patients na may PUD, pwede naman ikaw magkaroon ng PUD na wala ka namang cirrhosis, no? So, better yung prognosis mo kasi clinically less yung comorbidities. Patients with cirrhosis presenting with ugib should have urgent endoscopy within 12 hours. Yung patients may PUD, kailangan sila may endoscopy within 24. Ito may patients na may esophageal varices, kailangan sila yung endoscopy within 12. So, mas urgent yung endoscopy mo sa mga patients na may esophageal varices. And kung 3 days yung PPI sa mga patients na may PUD, sa mga patients na may esophageal varices, yung ang ibibigay mo is hindi PPI, ang ibibigay mo is vasoactive agents, mga octreotide, vasopressin, yung tawag na IV vasoactive agents. Mga IV vasoactive agents yan, binigay sila for 2 to 5 days instead of 3 days sa PUD dito sa esophageal varices, 2 to 5 days. And then, tandaan mo, may isa pa tayong pwedeng gawin. Pag persistent or recurrent yung bleeding in patients with esophageal varices, despite endoscopic and medical therapy, nag-endoscopic therapy ka na, nag-medical therapy ka na, nag-vasoactive agents ka na, kailangan may consider na yung kailangan may consider na yung patient baka mag-benefit sa tips. Yung transjugular intrahepatic portosystemic shunt, yun yung tips. So, it should be considered in the first 1 to 2 days of hospitalization for acute variceal bleeding in patients with, so hindi sa lahat ng patients na may chronic liver disease dapat mo consider tips, hindi sa lahat. But consider mo na siya sa mga patients na may advanced liver disease or child PU class C. Di ba mga child PU class C yung mga may score na 10 to 13, di ba? Yung child PU, di ba scoring siya sa mga patients with chronic liver disease? Lima yung factors na kailangan consider sa pag-score ng child PU, di ba? That's BAIAE. B, so that's bilirubin levels, INR, presence of ascites, di ba? And then, bilirubin, albumin levels, INR, and then ascites, the presence of ascites or encephalopathy, no? So, yun yung mga kailangan consider. So, urgent endoscopy nga. As you can see there, no? Actively spurting, no? Yung bleeding varix, no? So, ang ginagawa natin dyan, we can do EVL. Makikita nyo sa mga reports sa chart, EVL, endoscopic variceal ligation. So, that's endoscopic ligation, and then we can also give concurrently IV vasoactivations in the form of octreotide. Makikita nyo if you're doing PGI chips sa PGH, but you can see what encounter nyo doon is octreotide. Sometimes may nag-30% if present, pero hindi lagi. And then tips. And then, so yung mga esophageal varices, hindi lang lagi sa esophagus, hindi lang sa esophagus mga varices. Pwede siya mag-develop sa stomach, as gastric varices, pwede sa small and large intestine, small and large intestinal varices. Okay? And then, so yun yung second most common, di ba? Yung esophageal varices. Meron tayong Mallory Weiss Ang class presentation ng patients with Mallory Weiss no? Patient na uminom ng marami, pagkatapos uminom ng marami, sumuka ng malala, as in nagre-retch ulit-ulit, nag-vomit ulit-ulit, nag-cough ulit-ulit after uminom ng alak. And then eventually nagkaroon siya ng hematemesis. So that's the classic presentation of patients with Mallory Weiss. So, usually, on the gastric side siya, the gastric-esophageal junction, and in most cases, it stops siya spontaneously. So, nung clear ako, nakita na ng gano'n, dalaga na nag-vomit and nag-retch, and then may hematemesis na minimal lang naman, and then nawala din eventually. Okay? Pero yun nga, it may recur in as much as 10%. No? It's not as common as PUD or varices. Ang management nito, pwede tayong bigyan ng antiemetics. For example, metoclopramide ganyan. Pag may active bleeding, pwede natin siyang i-hospitalize for 1 to 2 days and then clear the bleeds for 1 day. And then we also have erosions, no? Endoscopically visualized breaks that are confined to the mucosa. They do not cause major bleeding kasi wala namang arteries or veins in the mucosa, unlike yung ating varices and yung PUD. Kasi pag sinabing PUD, pati ulcer. So ulcer is mas malalim than erosions. And may mga blood vessels ka na dun sa ulcers. Dito sa erosions, walang arteries or veins in the mucosa. Most important cause of gastric and duodenal erosions are NSAID use. Okay? Other causes are alcohol intake, pwedeng H. pylori or SIRMI or stress-related mucosal injury. So ano yung stress-related mucosal injury? Usually nakita niyo yan, no? Sa mga diagnosed sa mga patients critically ill na sa ICU pag ikaw ay nag-duty sa ward or sa ICU. Nangyayari lang siya only in extremely sick patients, yung mga trauma patients, major surgery, yung mga may patients na may burns na more than 1/3 of the body surface area. So ang tawag dun sa ulcer na yon, sa mga patients na sa mga erosions na nangyayari sa mga patients may ulcers nga na nangyayari sa mga patients na may burns, ang tawag dun ay Curling's ulcer. Okay, Curling's ulcer ang tawag dun sa ulcer na nangyayari, gastric ulcer na nangyayari sa mga patients na may burns. So and then meron din tayong ulcers na nangyayari sa mga patients na may major intracranial disease, ang tawag dun sa ulcers na yun, Cushing's ulcer. So paano niyo ma-remember yung difference ng Curling's sa Cushing? Yung Curling's ulcer nangyari sa mga patients na may burns, tandaan nyo mnemonic na burned by the curling iron. No? Pag nasunog ka ng curling iron sa buhok, so burned by the curling iron, patients with burns suffer from Curling's ulcer. Patients naman na may major intracranial disease, they tend to have Cushing's ulcer. So kasi, so parang ang mnemonic doon is cushion the brain. So you have to cushion the brain para hindi magkaroon ng Cushing's ulcer. Okay? So Cushing's ulcer sa brain, sa brain disease of major intracranial disease, and Cushing's ulcer sa mga patients na may burn. Other causes, okay? Neoplasms, vascularizations, Dieulafoy's lesion. So what's Dieulafoy's lesion? It's an aberrant vessel in the mucosa. So it's a bleeding from a pinpoint mucosal defect. Medyo mahirap makita in endoscopy kasi nga pinpoint mucosal defect lang, no? So kung na-rule out mo na through upper endoscopy and colonoscopy,
primary cause of in-hospital
wala kang makita sign of bleeding failure. You can naman yung most common cause of
out of hospital deaths from stain.
Correct answer. And usually they have pure GI bleeding. They usually have intestinal sources of bleeding.
Chronic coronary syndrome.
No source of GI bleed ang na-identify.
Which of the following
characteristics are less likely point anginal testing. Hypertension habang nag-increase yung age kasi associated with the adoption of the Western diet, no? So dahil mas mataas yung mga patients na may hypertension and diabetes, na associated din as risk factors with patients with heart failure. So follow talaga na nag-increase yung prevalence with age. No? So sa ito yung mga different etiologies of heart failure ng HFrEF or reduced ejection fraction or depressed ejection fraction. Pag sinabing HFrEF or reduced ejection fraction, depressed ejection fraction, the ejection fraction, pag sinabing reduced is less than 40% yung ejection fraction. Nakita nyo yun doon sa to the echo na report. Ang common causes ito sa mga more than 40 years old ay the following. Sa mga less than 40 years old, pwedeng mag-cause ay Meckel's diverticulum. Di ba nakita niyo yung disease process na yun sa mga pediatric patients, no? So most common cause kasi siya significant SIGI bleed in children, no? Colonic sources of bleeding. The most common pag tinanong sa inyo is most common cause of lower GI bleeding without any other walang ibang sinabi na exceptions or whatever, qualifications. The answer is hemorrhoids. But pag inalis mo yung hemorrhoids, di ba the most common cause of lower GI bleeding is hemorrhoids, di ba? Pero pag ang tinanong sa iyo is if you exclude local anal processes such as hemorrhoids, if you exclude that, the most common cause of lower GI bleed in adults is diverticulosis. Okay? Excluding hemorrhoids or local anal processes, the most common cause of GI bleed is diverticulosis. Okay? So in children and adolescents, the most common colonic causes with significant GI bleeding are IBD, or inflammatory bowel diseases, and juvenile polyps. Okay? So ang diverticulosis, walang pain. Tandaan nyo yun. Ang description ng diverticulosis ng GI bleeding is abrupt, sometimes massive, usually painless. Okay? Often from the right colon, and chronic or occult bleeding is not characteristic. Kasi nga, may makikita tayo yung dugo na dinudumi niya. Hematocrit talaga. So yung chronic or occult bleed, hindi siya from diverticulosis, less likely. No? So if a patient presents, with GI bleeding, this is for example with melena or hematochezia, ano naman gagawin? Punta sa ER. In the initial assessment of patients with GI bleeding, yung first step na gagawin natin is to measure heart rate and PPY kasi that will tell you how urgent and massive the bleeding is. If the patient is hemodynamically unstable, magbabago rin yung treatment in cases of LGI bleeding as you will see in the next slide. No? Kasi pag hemodynamically unstable, iba yung gagawin mo in terms of in a patient with LGI bleeding. No? And tandaan mo, the hemoglobin will not fall immediately. So hindi mo pwedeng gamitin yung CBC as panukat kung gaano ka-urgent yung bleeding in a patient with GI bleeding. Why? Kasi people bleed whole blood. Hindi naman madidilute. Ibig sabihin, di ba ang measure ng hematocrit is kung gaano ka relative to the plasma serum, gaano ka-concentrated or diluted, di ba? So, pag nag-bleed yung patient ng whole blood, ganun pa rin magiging result ng hematocrit. Hindi siya mababago. Kasi hindi naman madidilute or makakoncentrate yung blood. Kasi same amount lang ng serum and formed elements yung i-bleed ng patient. Di ba? So, kahit mag-bleed siya ng marami, same lang yung magiging result ng hematocrit. So, hindi siya or hemoglobin, hindi siya mababago acutely or immediately. Okay? Pero after a few days, mo lang makita na bumabagsak na yung hemoglobin and hematocrit. And by that time, nahuli ka na sa management. Hindi ka nagsali ng dugo, hindi ka nag-endoscopy. So, hindi mo pwedeng pagbasehan yung CBC. Okay? Additional clinical findings in patients with GI bleeding is hyperactive bowel sounds because the presence of blood in the stomach or in the small intestine will stimulate peristalsis kasi irritant yun sa GI mucosa. So that will lead to hyperactive bowel sounds and elevated yung BUN. Why? Kasi nagkakaroon ng volume depletion kasi nag-bleed yung patient, di ba? So magkakaroon ng volume depletion and ma-absorb yung mga hemoglobin which are proteins or na nandun sa GI lumen, ma-absorb sila into the small intestine. So tataas yung BUN. Okay? So, this is an algorithm to follow in patients with lower GI bleeding. Ito yung suggested algorithm natin. It depends sa hemodynamics. Kasi sabi ko kanina, kung hemodynamically unstable, yung patients yung bagsak yung BP, cold clamp extremities, actively bleeding, ang unang gagawin is upper endoscopy. Kasi sabi ko kanina, di ba? In patients with hematochezia, pwedeng yung hematochezia nila is dahil sa sobrang massive ng bleeding nila from an upper GI source, di ba? You have to firstly, you have to rule that out. Kasi yung hematochezia, di ba, sabi natin galing sa lower GI, pero pwede siya sa upper GI kung massive. Okay? So, kung may hemodynamically unstable, tas hematochezia, baka dahil sa upper GI source. After mo ma-rule out yun, titingnan mo kung stable naman siya or hindi. Kung too unstable pa rin yung patient, you can go and do angiography. If it still persists, the bleeding still persists, and still unstable in patient, still unstable, you can do surgery. Now, if pagkatapos sa angiography, medyo nag-stabilize na siya, you can do colo. Or, kung pagkatapos sa endoscopy, naging stable siya, you can do colo. Kasi nga ang colo, pwede mo siyang gawin lang if you're able to prep and the patient is kung naging more stable na siya, hindi na siya actively bleeding, or nag-stabilize yung BP, no? So, pwede ka mag-colonoscopy. So, in patients with no hemodynamic instability, sabihin okay yung BP niya, it depends sa age naman. If the age is more than equal 40 years, colonoscopy. Sorry, meron dapat line dito. Lagyan ko na lang ng line, para hindi kayo malito. So, age is more than equal 40 years, diretsong colo. Okay? Pag less than 40 years, you can choose between flexible sigmoidoscopy or colonoscopy. When do we choose colonoscopy for patients na less than 40 years? If more copious yung bleeding, or may family history of colon cancer, or may IBA, no? Pero kung wala nang mga ganyan, you can do flexible sigmoidoscopy. And then after mo mag-colonoscopy, pag nakita mo yung site, okay na. If nakita mo yung site and the bleeding persists, you can do angiography and surgery. As you can see, no, parehas yung, pag nag-persist yung bleeding, parehas yung pathway na angiography, and then if the bleeding persists, surgery. Dito ganun, no? Angiography, and then bleeding persists, and then surgery ulit. So halos parehas yung kanilang pathway, no? If the site is not identified after upper endoscopy and colonoscopy, if the site is not identified, and ito kasi yung ano mo dyan yung pathway mo nag-upper endoscopy ka, tapos nag-colo ka, tapos wala pa rin ikaw nakita, work up ka na for small intestinal bleeding or obscure obscure GI bleeding. Na most likely, di ba sabi natin, ang mga obscure GI bleeding most likely nanggaling sa SI or sa small intestines. So, small intestinal or obscure GI bleeding na management, kung massive bleeding, do angiography, no? As we mentioned kanina. Bakit angiography? Kasi we need to find the source agad, no? So, sa management, syempre we have to stabilize the BP kung actively bleeding patient. We can give crystalloids, no? But eventually, you will have to transfuse blood. So, how do we transfuse blood? And when? No? Magsasalin ka na ng dugo pag hemoglobin falls to less than 7. Okay? This is what we call restrictive transfusion. Kasi studies found liberal transfusion, pag sinabing liberal as opposed to restrictive. Pag sinabing liberal transfusion, it means nagba-blood transfuse ka when the hemoglobin falls to below 9. So, mas lower yung threshold mo magsalin. Di ba? Kasi 9 pa lang, salin ka na. Yun yung liberal transfusion. Pero they found na mas mataas yung mortality rate. So, ang mas recommended ngayon is restrictive transfusion, which means pag yung hemoglobin nag-fall lang to less than 7. Okay? So next case, patient presenting with dark-colored stool for 1 day. So black tarry stools na naman, di ba? So most likely baka ukib. Tapos may epigastric pain siya, worse between meals and heartburn. So between meals, no? Pagbuto with epigastric pain, no other comorbids, no other meds, hindi nag-take ng NSAIDs. And then normal yung may epigastric tenderness. Stool fit positive, sabihin may presence of occult blood, no? Sabihin may occult bleeding na chronic. Tapos nung nag-EGD, may nakita ulcer na duodenal. Tapos rapid urase test positive. Ano yung sabihin na rapid urase test positive? So it means positive sa presence of H. pylori, no? So yes, it's a case of PUD or peptic ulcer disease, the most common cause of upper GI bleeding na nasabi natin kanina. The second one is esophageal varices, yung second most common cause of upper GI bleeding na nasabi natin kanina, di ba? So ang description ng definition ng peptic ulcer is disruption of mucosal integrity of the stomach and duodenum. Ang definition ng peptic ulcer is more than 5 millimeters in size with depth to the submucosa. Kaya nga siya nag-bleed ng marami kasi nga may veins and arteries ka sa submucosa. Suppose sa erosions na walang arteries or veins, so less likely siya mag-bleed ng marami. Often chronic, ang PUD, most common risk factors, H. pylori and NSAIDs. Okay? So, ito na pinakita natin kanina na force classification, nagde-depend dyan kung tayo ay mag-endoscopic therapy or magbibiga and kung mag-intensive PPI, no? Na therapy. And then we have two locations for the PUD. It can either be at the duodenum or at the stomach. Because duodenal ulcers is most commonly occurs in the first portion of the duodenum. Pagkatapos nung stomach is the first portion of the duodenum, no? Most commonly within 3 centimeters from the pylorus, no? H. pylori and NSAIDs account for the majority of duodenal ulcers, and ang makikita mo dyan is increased yung gastric acid secretion. As opposed sa gastric ulcers na normal or decreased yung gastric acid output, no? Now in gastric ulcers, tandaan niyo, as opposed sa duodenal ulcers, ang gastric ulcers ay dapat lagi ninyong iisipin na it may represent malignancy. Gastric ulcers, malignancy. Duodenal ulcers, less likely. Okay? Rare. Malignant duodenal ulcers are rare. Ang gastric ulcers associated with malignancy. Kaya nga dapat, pag nakita ng pagka-endoscopic therapy, nakita na yung PUD ay gastric ulcer pala, dapat i-biopsy. Okay? So this is the first part of the duodenum. Within 3 centimeters from the pylorus, within 3 centimeters, then most commonly nag-occur ang duodenal ulcers. Pag mga gastric ulcers, often found distal to the junction between the antrum and the acid secretory mucosa. So mga dito sa mga part na to. No? And sabi ko nga dapat iba-biopsy, tandaan nyo ha. So ang common cause ng PUD is H. pylori. So, nag-live talaga siya within the aggressive environment of the acidic stomach. No? And ang transmission niya is oral to oral or fecal-oral yung route. Okay? Ang mga, so dahil oral to oral or fecal-oral yung route ng transmission ng H. pylori, so higher yung colonization rate sa mga patients na poor socioeconomic status kasi yung tabi-tabi ang bahay, hindi nagugas lagi ng kamay, poor hygiene practices, less education. So higher yung colonization rate ng mga patients na H. pylori. Okay? Other risk factors na associated with poor socioeconomic status and less education is domestic crowding, unsanitary living conditions, as I said kanina. Kasi nga, kung unsanitary living conditions mo, most likely mahawa ka kasi nga oral to oral, fecal-oral yung route na ng H. pylori, and unclean food or water. So these are the factors that play a role in the pathophysiology of H. pylori. So meron tayong mga bacterial factors ng H. pylori, host factors, diba? And then they will all lead to these 4 disease processes na pwedeng i-cause ng H. pylori. Okay? Pwedeng chronic gastritis lang i-cause ng H. pylori, pwedeng chronic gastritis lang and hindi PUD. Pwedeng gastric maltoma or malt lymphoma or gastric cancer. Okay? So ito maganda tong figure na to na makikita niyo sa Harrison. So after infection of H. pylori, the H. pylori will become from acute will become chronic infection if not treated with antibiotics. Kasi ang treatment for H. pylori infection is antibiotics, no? Now it will depend after ma-infect ng chronic H. pylori kung ano yung magiging outcome niya. So if the gastritis that the H. pylori cause is antral predominant, no? So from pag antral predominant yung gastritis na kinos ng H. pylori, it may lead to a duodenal ulcer. Okay? Ano? Yan. Okay. So kung non-atrophic naman yung pan-gastritis ang kinos ng chronic H. pylori infection, it can lead to a maltoma, no? Maltoma or malt lymphoma. And then, pag corpus predominant naman, it can become a gastric ulcer or intestinal metaplasia leading to gastric cancer. So, ibig sabihin, ang point ko is, depende kung saan siya, kung anong klaseng gastritis or saan yung location ng gastritis, depende doon kung ano yung maging eventual outcome ng H. pylori infection. Kaya nakalagay dito ng location, kaya mahalaga yung location. Kasi kunwari, corpus predominant atrophic gastritis yung kinos ng chronic H. pylori infection, malas ka kasi, pwede mag-lead to gastric cancer. Okay? Pero lahat itong gastritis na to, na locations, can all lead, on the other end of the spectrum, can all lead to being asymptomatic H. pylori infection lang. Okay? Next, the most frequent finding is epigastric tenderness. So, yun yung pinresent natin patient kanina, epigastric tenderness. Okay? And kung mag-bleed na yung patient, pwede magkaroon ng dehydration from vomiting or GI losses, and then pag nag-perforate, magkaroon ng acute abdomen, board-like abdomen, and then pag nag-obstruct, pwede magkaroon ng succussion splash or auscultation of the abdomen. So, ito yung mga common complications ng mga patients na may PUD. Ang most common is bleeding, second most common is perforation, next is obstruction. So, yan yung pinakamarami is bleeding and then perforation, and then least is obstruction. So, tandaan nyo yung mnemonic natin na BPO, yung BPO. So, kung ano yung most common. Kasi tinatanong yan. Minsan nga, tinatanong ano yung least common lang. Kailangan matandaan nyo na obstruction yun. Okay? So, in the evaluation of a patient with PUD, in a patient with new onset dyspepsia, dyspepsia, no, lagi sumasakit yung epigastrium, that's more than 40 years old and may alarm symptoms. First, you have to exclude kung may GERD siya, sabihin may water brush, or like nagre-reflux ba yung kinakain niya, or may biliary pain na nagre-radiate sa right shoulder, sa may right shoulder blade, okay, or precipitated by a fatty meal. So, yun yung mga ano natin, di ba? Yung mga sinasabi na biliary, pwedeng dahil sa biliary etiology, yung epigastric or right upper quadrant pain, di ba? So, exclude nyo muna yun. And then, yung dyspepsia for more than 40 years old and may alarm symptoms, automatically, may alarm symptoms eh. So, kailangan may refer sa gastroenterology. I will tell you later kung ano yung mga alarm symptoms natin. So, pero kung less than 40 and wala namang alarm symptoms, you can already do non-invasive H. pylori testing. Kung positive, edi, targeted na yung therapy natin, kailangan natin yung bigyan antibiotics, anti-H. pylori therapy for 4 weeks. And then after that, you have to confirm eradication of the H. pylori by urea breath test. Okay? Pag nag-persist, saka mag-refer sa GI. Pero kung kunwari, yung onset dyspepsia, more than 40, may alarm, less than 40, walang alarm symptoms, nag-HP testing ka, negative for H. pylori, pwede ka mag-trial ng H2 blocker or you can already refer to a gastroenterologist. Okay? So, meron tayong iba't ibang tests for detection of H. pylori. Meron tayong dalawang klase. Okay? Meron tayong invasive, no? And meron tayong non-invasive. Okay? Sa invasive, yung pinaka-specific, no, is yung, as you can see here, no, pwedeng histology, pwedeng rapid ureases. No? Ang maganda kasi sa mga invasive testing, for example, yung culture, ang maganda doon, it allows you to determine, no? It allows you to determine yung antibiotic susceptibility ng H. pylori. Kasi hindi lahat ng H. pylori ay susceptible to amoxicillin, no? Kasi di ba yung binibigyan natin ng gamot, usually, no, OCA, omeprazole, clarithromycin, and amoxicillin, no? Hindi lahat is susceptible to those antibiotics. So you have to know kung ano yung susceptibility ng H. pylori. And then, so yun yung mga invasive, no? Pwedeng rapid urease test, as yung ginawa sa ating patient. Or non-invasive, in the form of serology, urea breath test, or stool antigen, urea. So ang tatandaan ninyo dito, ang serology, ito madalas din natin, ang serology, tatandaan ninyo, hindi yan useful for early follow-up. Kasi syempre ang ginagamit yan is dahil nga serology siya, hindi yung mga antibodies na hindi naman bumaba agad after mo matreat yung infection. So magiging false positive ka lang dyan kung gumamit ka ng serology for early follow-up. So ang tanong mo is, anong pwede natin gamitin para for follow-up and to confirm eradication of H. pylori? Pwedeng urea breath test, okay? Kasi nga, simple, rapid, useful for early follow-up. Ang isa pa pwede natin gamitin is stool antigen, pwede natin gamitin for follow-up, okay? Pero in terms of exams, no, kailangan niyo tandaan, pag ang tinanong, ano yung test for detection of H. pylori na pwedeng mag-cause ng false negative pag may recent use of PPIs, ang tatandaan niyo, yung mga test na nasa table na to na may word na urea. Ano yung tests na yun? Dalawa lang actually. Rapid urease test, rapid urease test, tsaka urea breath test. Rapid urease, same basic, tsaka urea breath test. So sila yung mga may words na urea. So pag yung mga may words na urea na yun, sila yung nagkakos ng false negative na test with recent use of PPIs, no? Antibiotics or bismuth compounds. So itong urea breath test, pwede rin siya maging false negative with recent therapy. So parang yung rapid urease, diba? It can lead to false negative with recent use. Yung urea breath test, ganun din. So tatandaan niyo yun, kasi pinatest yun sa mga exams. Ano yung pwede mag-cause ng false negative tests? Results pala. Next is PUD. Ano yung treatment natin? Yung goals natin dito, edi symptom relief kasi yun may reason ba't pumunta yung patient sa iyo. And then ulcer healing and prevent recurrence and complications. Yung complications natin, sabi nga natin na BPO, bleeding, perforation, and then obstruction. So how do we eradicate H. pylori? Combination therapy 14 days. Diba? Triple therapy is still recommended for a total of 4 to 6 weeks. Okay? And to test for eradication, UBT or stool antigen. So ito yung sinasabi ko kanina na OCA, no? Or yung triple therapy. OCA, O is yung PPI, omeprazole, OCA, omeprazole, clarithromycin, and then amoxicillin. Okay. For 14 days. Okay. Pero you have to know the susceptibility. Kasi if you know the susceptibility, you can go to other regimens. Itong mga to. Okay. May magamit din tayo ng levofloxacin, nitazoxanide, doxycycline. Depende. Okay. So, di ba yun? Pero sa natin yung PUD na cause by H. pylori. Ito naman yung PUD na cause ng NSAID-related injury ng PUD. No? If the patient has an active ulcer, based on endoscopy, nakita mo, tapos inalis mo na yung NSAIDs, no? Inalis mo na yung NSAIDs, you can use PPI or H2RA or yung mga cimetidine, ganyan. Pag kailangan, kung may active ulcer yung patient, tapos kailangan pa rin talaga i-continue NSAIDs, for example, wala kang ibang alternative, you can give the patient the NSAID and the PPI. Kung the patient wala namang active ulcer, gusto mo lang for prophylaxis lang, you can use a PPI or celecoxib. If the patient has H. pylori infection, syempre, edi yung OCA or yung other antibiotics na nandun sa regimen na pinakita natin kanina. Yan. Okay? Now, if kailangan mo rin malaman actually kung yung patient is may walang CV risk or may CV risk. Kasi yung mga patients na may CV risk, sila yung mga patients na kailangan mo bigyan ng aspirin. Sabihin, for example, yung mga patients na may ECS or nag-STEMI dati, kailangan ng dual antiplatelet therapy in the form of aspirin and clopidogrel. So kung yung patient is kailangan talaga ng aspirin, pag inalis mo yung aspirin sa kanyang regimen, maintenance medications, pwede siya mag-re-MI, diba? So kailangan talaga, for example, kailangan talaga ng aspirin dahil may CV risk nga siya. Pero so i-match mo siya dito sa columns na to. So itong row na to na meron nga siyang CV risk or kailangan talaga ng aspirin. Titingnan mo, low ba yung GI risk niya or high yung GI risk niya magkaroon ng bleeding. So pag yung patient ay wala namang GI risk from after if you give aspirin, so ito yung pwede mong ibigay na regimen. And then kung may GI risk naman siya, you can use this regimen. Okay? So other forms of treatment, di lang medical, sa patients with PUD, you can also do surgery. Okay, so pero i-discuss na yung details dun na sa surgery na subject ninyo. Yun yung mga highly selective vagotomy, gastrectomy with atherectomy, yung mga ganun na, mga Billroth, yan. I-discuss na sa surgery part. Okay? So another case for GI, no? 27 male student, epigastric pain, heartburn for the past year, relieved by omeprazole worsened by big meals, okay? Reports chronic cough, okay? Heartburn, chronic cough, and mild epigastric tenderness, pero normal yung labs. So naisipin nyo, so may heartburn daw eh. So dun pa lang, no? Mukhang GERD na yun, okay? So yung GERD or gastroesophageal reflux disease, that is the most common esophageal disorder. And yung dominant mechanism nito, may mechanism kasi, dominant mechanism EGJ or esophagogastric junction incompetence. Kasi syempre kung incompetent, hindi lagi naka-close yung esophagogastric junction, nagre-reflux yung gastric or gastric acidic contents into the esophagus, no? So yung causticity ng gastric reflux state na yun extends beyond hydrochloric acid. Hindi lang dahil acidic yung hydrochloric acid, no? Yung nagkakaroon ng mucosal erosion and activation of afferent sensory nerves. So ito yung iba't ibang mechanisms for GERD, transient LES relaxations, LES or LES hypotension and anti distortion of the EGJ inclusive of hiatus hernia. Other factors which tend to exacerbate the reflux is these factors. So kung makikita nyo, no, kung malaki yung chan ng patient, dahil may abdominal or central obesity, and then lagi siyang kumakain ng sobrang dami, gluttony, katulad for example, ng ating patient na worsened by intake of big meals, for example, siguro kung nagbubuffet lagi, no? mas malaki yung tiyan niya, tapos may gluttony, it can lead to paulit-ulit na GERD. Okay, so the gastric reflux state leads to costic injury. The typical symptoms is katulad ng symptom ng ating patient, ng medical student na yun. Heartburn and regurgitation. So yung heartburn parang susunod dito sa may sternum. And dahil yun sa reflux state ng acidic contents na yun from the stomach to the esophagus papuntang throat, pwedeng pumunta actually sa may larynx, no? Which leads to chronic cough. So yun yung isa pa sa mga esophageal symptom na present ng ating patient na medical student. So heartburn, chronic cough. And dental erosions kasi acidic yung acidic yung reflux state, no? So pwedeng dahil sa acid na yun, magkaroon ng dental erosions. So nagre-regurgitate, regurgitation with direct contact between the reflux and supraesophageal structures. So yun yung reason natin chronic cough, no? Kasi it activates the afferent nerves leading to efferent vagal reflexes leading to cough, bronchospasm, or even arrhythmias. So, ano yung mga complications ng GERD? Bakit kailangan i-treat yun? Siyempre, yung alam na, pwede mag-lead to chronic esophagitis dahil nga, acidic yung reflux state. Pero yung kilala natin na kailangan natin i-prevent is yung esophageal and adenocarcinoma. Okay? So, itong esophageal adenocarcinoma na to, this is the most severe histologic consequence ng GERD. No? So, in patho, what you will see is specialized columnar metaplasia. Sa patho, it's also described as tongues of salmon-colored mucosa extending proximally from the gastroesophageal junction. So, yung tongues of salmon-colored mucosa, yun yung description ng virus metaplasia sa patho. Okay? So, anong kasunod na gagawin natin? Kailangan ba nating sa tingin mo ba pag binigyan natin ng PPI, magre-regress yung Barrett's metaplasia? There's no evidence. No? There's no high-level evidence that confirms that anti-secretory therapy in the form of PPI ay pwede mag-cause ng regression. So that's sadly. No? So dati, esophagectomy yung gold standard sa pag-treat ng GERD, pero now it's mucosal ablation therapy. Kasi medyo morbid kasi yung esophagectomy is. No? So other lifestyle modifications in the patient with GERD is avoidance of food that reduce LS pressure, acidic food, no? Mga fatty food yung nagre-reduce ng LS pressure, alcohol, mint, coffee or tea. Plant-based foods, citrus foods, mga acidic foods naman that are inherently irritating. Diba? So sa pharmacologic approach, we have to inhibit gastric acid secretion in the form of giving PPIs, no? And usually for an indefinite period. And syempre, other non-pharmacologic treatment, edi weight reduction. Diba? And other methods is elevation of the head of the bed and avoidance of eating before matulog. Diba? So next case, since that's the time of treatment ng ating patient na may GERD, is a 42 female who presented with epigastric pain radiating to the back and shoulders, accompanied by nausea vomiting. Nagdidrink siya ng alcohol once a month. May direct tenderness epigastrium, distended yung abdomen, and may discrete discoloration of both flanks. So medyo giveaway ito, discrete discoloration of both flanks, tapos may epigastric pain. So it's a case of acute pancreatitis. No? It's a severe acute pain in the abdomen or the back. It should suggest the possibility of acute pancreatitis. So the most common cause of acute pancreatitis, no, is gallstones pa din. So makita nyo yun sa yung mnemonic sa I am platinum, gated, G-A-T-E-D. G is A, is T, is E, and then D. Yung G doon is gallstones kasi yun yung most common. The second most common is alcohol. So gated, no? And then pwede rin hypertriglyceridemia, pero usually dapat more than 1,000. Okay? The pathogenic mechanism of acute pancreatitis is the activation of proteolytic enzymes in pancreatic acid cell rather than in the lumen. So ibig sabihin, nag-auto-digest, dinadigest ng pancreas sa sarili niya. The major symptoms, abdominal pain. Steady, boring pain, nag-radiate sa back. Okay? So it is accompanied by nausea, vomiting, low grade fever, tachycardia, hypotension. It can lead to hypovolemia dahil sa exudation of blood into the retroperitoneal space kasi nasa retroperitoneum yung pancreas. And dahil sa systemic effects of proteolytic and lipolytic enzymes, they can all lead to shock, hypovolemic shock. Clinical manifestations ng patient with acute pancreatitis, abdominal tenderness and muscle rigidity, diminished or absent bowel sounds, pero ng ating patient na yun. And then, it can lead to yung patient na may discoloration sa kanyang flanks. It can lead to Collins sign or Turner sign. So, paano yung tatandaan? Paano kayo hindi mo confused, no? So, yung Collins sign starts with letter C, no? For letter C, Collins sign. Letter C is at the center of the body. Kasi nasa center ng body yung umbilicus, ibang lalo sa kanan mo sa kaliwa, nasa gitna yung pusod. So, Collins sign, center of the body, faint blue discoloration around the umbilicus. Yung Turner sign naman, paano ka mag-turn? Di ba yung flanks is nasa left or right? Nasa left or right, di ba? So, paano ka titingin sa flanks mo? You turn left or you turn right, di ba? So, Turner sign, blue, red, purple, or green, brown discoloration of the flanks. So, dahil bakit nagkaroon ng discoloration? Kasi nagtatrack actually yung blood from the retroperitoneum papunta sa flanks, nagtatrack siya. So, it reflects tissue catabolism of hemoglobin from severe necrotizing pancreatitis with hemorrhage. So, hemorrhage talaga siya, no? Other lab findings in patients with acute pancreatitis. So, actually, tatlo lang. 2 of 3 yung kailangan mo ma-satisfy in order to diagnose acute pancreatitis. Yung una is epigastric pain na typical of acute pancreatitis. Number 2 is kung elevated yung labs na serum amylase or lipase. Pero hindi lang dapat elevated, dapat 3 times elevated. Okay? Number 3 is imaging. CT imaging. Okay? So, ang elevated serum amylase and lipase na value na more than 3 times of upper limit of normal, it clinches the diagnosis. Pero dapat i-exclude muna yung gut perforation, ischemia, infarction, kasi they can lead to falsely elevated serum amylase and lipase. Pero mas specific yung lipase. Kung meron kang lipase sa labs, lipase na lang huwag kang mag-amylase. Right? And then, other findings sa laboratory is elevated hematocrit kasi nga hemoconcentrated yung patient dahil nga nag-lose siya ng fluids in the retroperitoneum. So, elevated yung hematocrit, actually harbinger of more severe disease ang elevated hematocrit. The value is more than 44%. If the hematocrit is more than 44%, it's a harbinger of more severe disease ng acute pancreatitis. And then nagkaroon ng perirenal azotemia kasi nagkaroon ng hypovolemia, so perirenal yung kanyang AKI with elevated BUN, which is also a risk factor for mortality. Hyperglycemia, hypocalcemia dahil nagkaroon sa aggregation of calcium by fatty acids. Yung fatty acids dahil sa fat necrosis dahil dun sa autodigestion ng acute pancreatitis. Okay? Now, in terms of diagnosis, ay nabanggit ko na kanina, 2 of 3 ang kailangan mo na ma-satisfy. Typical abdominal pain that radiates to the back with elevation serum lipase and or, hindi and ha, and or. So, you can do na serum lipase lang, wala na this kung limited yung funds. And then, cross-sectional abdominal imaging, CT findings of acute panc and CT of the abdomen. 2 of 3 lang, ma-satisfy mo acute pancreatitis na yun. So, we have 2 phases in the disease process of acute pancreatitis. Kung less than 2 weeks pa lang yung patient, it's acute pancreatitis, early phase, defined by clinical parameters rather than morphologic findings. So, it's mostly they present with SIRS or severe inflammatory response syndrome. And actually, in patients with acute pancreatitis, hindi tayo lagi nire-request ng CT on admission. Nire-request natin CT scan of the abdomen. The patients with acute pancreatitis, nire-request natin siya during the after 48 hours. Kasi wala akong makita within 48 hours. Kaya sabi dito, not needed during the first 48 hours. Pero, for example, hindi nag-improve yung patients after a few days after nung kanya admission. And then, by that time, pwede mo na i-diagnose yung patient as having acute pancreatitis with persistent organ failure. And in those cases, kailangan mo mag-imaging. Bakit mo kailangan mag-imaging? Ang hinahanap mo sa CT of the abdomen. Ang hinahanap mo dyan is kung yung patient ba is mayroong necrotizing pancreatitis. Kasi yung necrotizing pancreatitis, mas complicated siya na subtype ng acute pancreatitis, mas associated with more mortality. No? So, in terms of severity, meron tayong mild, moderate, and severe. Diba? So in mild acute pancreatitis, the disease is self-limited. Pwedeng mag-subside spontaneously. And in moderately severe, pwedeng magkaroon ng local complications that requires a prolonged hospitalization for more than 1 week. Pero pinakadelikado dito is yung severe na acute pancreatitis kasi it leads to persistent organ failure na kailangan natin mag-CT scan to find for necrotizing pancreatitis. And necrosis, in those cases, kailangan operahan yung gano'n, no? Pero, depende pa actually. Depende kung yung necrosis is may infection. Kasi kung yung necrosis may infection, saan tayo magbibigay ng antibiotics? Hindi tayo nagbibigay ng antibiotics na prophylactically in patients with acute pancreatitis. Okay? Pero sa lahat ng nasabi ko, the most important treatment intervention in patients with acute pancreatitis is aggressive fluid resuscitation. May ganyang patients na may acute pancreatitis na napunta sa ER, na doon sa previous hospital, isang bote lang ng PNSS yung naubos in a span of like 2 to 3 days. O kaya siya nag-complicate kasi sobrang bagal nila mag-resuscitate, mag-fluid resuscitation kasi tinitipid sa PNSS na dapat hindi. Kasi the most important treatment intervention in patients with acute pancreatitis is aggressive fluid resuscitation. Okay? It could be LR or PNSS, pero LR daw yung better crystalloid. Okay? So, and then paano malaman na nag-improve na yung patient after fluid resuscitation? You use the hematocrit and the BUN. You can monitor that serially. Okay? And then, pag yung patients ay may abdominal pain, siyempre after relieve abdominal pain with IV narcotic analgesics, assess the severity using the BITAP score, and search for other etiologies. Mamaya may gallstones pala, kaya nag-jaundice yung patient and may acute pancreatitis. No? And then you have to put the patient on NPO, but you have to consider resuming enteral nutrition. Ibig sabihin, you can start with clear liquids and then clear liquids and then progressing to soft diet and then full diet 2 to 3 days after. So progression yun ha, you have to start with clear liquids muna. 2 to 3 days after nung event na acute pancreatitis, you have to consider kung pwede na siya mag-enteral nutrition. Okay? Instead of PPN, hindi tayo dapat mag-PPN. Okay? So dapat papakainin talaga sa bibig. Okay? So sa follow-up care, you have to assess for development of diabetes kasi nga nag-auto-digestion, na-digest din siguro yung mga beta cells. So pwede silang mag-decrease insulin production sa body leading to diabetes, exocrine insufficiency kasi syempre auto-digestion nga nasira na yung anatomic integrity ng pancreas, no? And development of infected fluid collections, mga pancreatic pseudosis, no, that develops more than 4 weeks after magkaroon ng pancreatitis, no? And then assess kung dahil most common causes gallstones, baka kailangan natin mag-cholecystectomy during hospitalization or within 4 to 6 weeks of discharge ng mga patients na acute pancreatitis. Ang dahilan ng acute pancreatitis is dahil sa gallstones, okay? So next case ng ating patient is a 45-year-old male who presented at the ER for fever, abdominal pain, and jaundice with no other known comorbids, no prior surgery, hospitalization. He drinks 8 bottles of beer daily, no? And sa physical exam, very telling, no? Bakit? Well, una may fever siya, and then mukhang may anemia, pale pattern conjunctivae, and then may scleral icterus, so may jaundice, no? Spider angiomata, liver edge na may hepatomegaly, and may fluid wave, so may ascites pa. Okay? So may anemia siya, thrombocytopenia, mataas yung liver enzymes, no? And prolonged yung PP. So very obvious naman yung diagnosis na ito ay isang case ng chronic liver disease or liver cirrhosis. So maraming etiology ang cirrhosis. Pwedeng alcoholic, pwedeng NAFLD or non-alcoholic fatty liver disease. So hindi siya nagiinom, obese lang talaga siya. So pwedeng doon yung cause ng liver cirrhosis, NAFLD, alcoholic cirrhosis, or pwedeng viral from hepatitis, for example, chronic hep C, hemochromatosis, and alcoholic liver disease. Okay. So ang pathologic na feature ng cirrhosis is sa patho, di ba? Development of fibrosis and architectural distortion with formation of regenerative nodules leading to a decrease in hepatocellular mass, reduced function, leading to alteration of blood flow. Kasi syempre kung may mga regenerative nodules ka sa liver, hindi na maka-flow ng maayos yung blood into the liver. So, una natin i-discuss is cirrhosis from excessive alcoholic intake. So, that's alcoholic cirrhosis. It's from chronic alcohol use na excessive. Okay, may tatlong stages yung alcoholic cirrhosis. So, before siya mag-lead to alcoholic cirrhosis, pwedeng yung liver magkaroon muna ng maging fatty liver muna from excessive alcohol intake, alcoholic fatty liver, and then alcoholic hepatitis, and pag hindi pa rin siya abstain from alcohol intake, eventually maging alcoholic cirrhosis. Okay? The nodules in alcoholic cirrhosis are usually micronodular, maliliit lang. Pero if you, with cessation of alcohol use, it may become mixed, may micro and macronodular cirrhosis. So non-specific yung symptoms of alcoholic cirrhosis, they could be vague, right upper quadrant pain, fever, nausea, vomiting, diarrhea, anorexia, and malaise. You have to be wary of the specific complications of chronic liver disease. Makita laging ganyan yung mga side effects or yung mga complications ng patients like cirrhosis, ascites, edema, upper GI bleeding, jaundice, and ceph, no? Dahil yung estrogen ay hindi na may metabolize na ng liver, so nagkaroon ng excess estrogen sa katawan, so nag-decrease yung body hair in patients sa men, gayong kumasya and testicular atrophy from excess estrogen, no? And then, dahil excess estrogen din, nagdadilate yung mga blood vessels, spider angiomas, pulmonary edema, so that's estrogen din. Then, dahil dun sa jaundice, scleral icterus, okay? And they also can lead to digital clubbing. Okay, clubbing. So hindi lang sa cardiac and sa pulmo diseases nagkakaroon ng clubbing of the digits, pwede din sa cirrhosis, edema, and ascites, as I mentioned kanina. Okay, sa labs ng patients na may cirrhosis, there could be anemia, okay? And then thrombocytopenia. Tandaan niyo, ito yung mahalaga niyo matandaan. Thrombocytopenia is an early finding in patients with alcoholic cirrhosis. And actually, it is the first indication of portal hypertension in patients with cirrhosis. First indication na yung patient na may portal hypertension na from liver cirrhosis is thrombocytopenia. Okay? Nakalagay yun sa Harrison's. And tinatanong din yan sa mga board exams. PLE, sa board exam ng internal medicine. Okay? And syempre, very useful din sa clinics. Syempre, tataas yung bilirubin kasi liver cirrhosis siya. The prothrombin time is prolonged. Kasi bakit? Yung mga clotting factors, di ba ginagawa lahat yun ay sa liver except for clotting factor A. So, pag nasira yung liver, dahil nga decrease sa hepatocellular mass, dahil nga cirrhosis, nababawasan na yung gumagawa ng mga clotting factors. So, nagpo-prolong yung bleeding, yung prothrombin time. Nagpo-prolong yung prothrombin time kasi nababawasan yung mga clotting factors. And it does not correct with vitamin K kasi ang vitamin K, kailangan lang naman siya for gamma carboxylation para maging active yung mga clotting factors na ginagawa sa liver. So kahit magbigay ka ng vitamin K, wala siyang saysay kasi in the first place, wala naman nagsisynthesize sa clotting factors na i-activate ni vitamin K. So with cirrhosis, it does not correct, the prothrombin time does not correct with vitamin K kasi wala naman clotting factors na i-activate si vitamin K kasi nga decrease ng hepatocellular mass na nagsisynthesize ng mga clotting factors. And then, elevated yung transaminases. Tandaan nyo, kailangan nyo malaman kung yung ratio ng AST to ALT. Okay? In patients kasi na may alcoholic cirrhosis, the AST to ALT ratio is usually 2:1. So paano nyo matatandaan? So paano nyo hindi ma-mix up na ALT to AST ratio siya? So dapat ang numerator is AST ha, hindi ALT. So paano nyo matatandaan? AST over ALT, AST ALT ratio. AST is San Mig light, no? San Mig light. AST over ALT ratio, San Mig light to AS is usually 2:1. Okay? Pag AST yung ratio na 2:1, galing siya sa San Mig nga, galing siya sa alcohol. So alcoholic cirrhosis, AST ALT ratio or 2:1. Important point na i-check sa mga patients na may alcoholic cirrhosis is to check for ongoing alcohol use and abuse kasi nga as we will discuss later, the treatment sa mga patients na may alcoholic cirrhosis is abstinence from alcohol. Kasi kahit mag-treat ka, tapos inom pa rin siya ng alcohol, wala namang mangyayari, okay? Well, pwede tayo mag-liver biopsy to confirm diagnosis, but we have to withhold alcohol, meaning nag-abstain siya from alcohol for at least 6 months to determine kung may residual or non-reversible disease. So, common din yung tinatanong ha, patient na may alcoholic cirrhosis, pwede na ba tayo mag-liver biopsy ngayon? Nagpunta siya sa clinic, ang sagot is hindi, wait for at least 6 months. As I mentioned kanina, cornerstone of therapy of alcoholic cirrhosis is alcohol abstinence, okay? So, hindi lahat na may alcoholic cirrhosis binibigyan natin ng glucocorticoids, no? Hindi lahat. It's only for patients with severe alcoholic hepatitis at nagko-compute tayo ng discriminant function. If the discriminant, so may formula yan, okay? So if the discriminant function is more than 32, that's the time na, and in a patient with severe alcoholic hepatitis, that's the time na bibigyan tayo ng glucocorticoids, okay? So hindi lagi. Okay? And syempre, you have to decrease the use of paracetamol. So kung sa normal na tao, ang max dose ng paracetamol is 4 grams, sa patients na may cirrhosis is 2 grams na lang, okay? So meron tayong cirrhosis from alcohol, meron tayong cirrhosis from chronic viral hepatitis. So meron tayong common na viral hepatitis na nag-lead to cirrhosis, no? We have HCV and Hep B, hepatitis C viruses and hepatitis B virus, okay? So what you will see is magkakaroon ng portal-based fibrosis with bridging fibrosis and nodularity. So sa pato, makikita nyo yung description ng cirrhosis from chronic viral hepatitis. Okay? So it differs, no? Kasi sa mga patients may hepatitis C na infection, 80% will develop, pagkatapos magkaroon ng acute hepatitis C infection, 80% will develop chronic Hep C. And 80% of those patients will non-develop chronic Hep C. 20 to 30 of that will develop cirrhosis over 20 to 30 years. As opposed sa mga patients na may Hep B infection, pagkatapos magkaroon ng acute hepatitis B, only 5%. Di ba dito 80? Dito is 5% lang magiging chronic Hep B. Pero 20% will develop cirrhosis. Okay? So ano yung mga signs and symptoms? Medyo the same sa alcoholic liver disease na yun yung mga jaundice, fatigue, okay? Malaise, vague RUQ pain, okay? So ang idadagdag mo lang sa mga laboratory na nirequest mo kanina is syempre HCV RNA testing and Hep B and yung DNA levels. Meron tayong table to show kung ano yung paano mo i-interpret yung serologic patterns na nire-request natin sa mga patients na may chronic Hep B or chronic Hep C. So, or Hep B and Hep C infection. So, ito yung mga currently nire-request natin na hepatitis profile. Yung nire-request mo sa lahat. Hep profile for Hep profile. So, HB-SAG or HBS antigen, surface antigen, anti-HBS, anti-HB core, HBE, antigen, and anti-HBE. Okay? So, yung commonly na nakikita ninyo sa clinics or sa wards, for example, sa wards, kung ang lagi ko nakikita dyan, madalas is chronic Hep B with low infectivity or chronic Hep B with high infectivity. Na yung differentiating factor lang ng high infectivity sa low infectivity is, so pag sinabing, ang nag-determine kasi ng kung high or low infectivity is kung the presence of HBeAg. So tingnan mo to, HBeAg is positive, positive siya in patients na may high infectivity. Okay? If the patient has negative HBeAg, kasi nga, positive yung anti-HBe, so kung negative siya dito, tapos positive siya sa anti-HBe, low infectivity. So what determines infectivity is yung presence of HBe antigen. Okay? And then, aralin nyo na lang itong mga susunod na other serologic patterns para malaman nyo rin kung ano yung interpretation nila. Okay? So other causes of cirrhosis, maliban sa chronic viral hepatitis and sa alcoholic hepatitis, alcoholic na cause is autoimmune hepatitis. Yung autoimmune hepatitis, ito yung mga hepatitis na may positive yung ENA, no? And anti-smooth muscle antibodies, no? And then we also have NASH or non-alcoholic steatohepatitis. Ito yung pwedeng endpoint ng mga patients may NAFLD or non-alcoholic fatty liver disease. They can go on and develop non-alcoholic steatohepatitis, which is then associated with the development of cirrhosis. Okay, so yun yung delikado. So ibig sabihin, hindi lang pala yung mga patients na nag-alcohol or yung patients na may chronic viral hepatitis, yung nag-develop ng cirrhosis, pwede mag-develop ng liver cirrhosis yung mga patients na obese. HBeAg is antigen. Okay? And then, aralin nyo na lang itong mga susunod na other serologic patterns para malaman nyo rin kung ano yung interpretation nila. Okay? So other causes of cirrhosis, maliban sa chronic viral hepatitis and sa alcoholic hepatitis, alcoholic na cause is autoimmune hepatitis. Yung autoimmune hepatitis, ito yung mga hepatitis na may positive yung ENA, no? And anti-smooth muscle antibodies, no? And then we also have NASH or non-alcoholic steatohepatitis. Ito yung pwedeng endpoint ng mga patients may NAFLD or non-alcoholic fatty liver disease. They can go on and develop non-alcoholic steatohepatitis, which is then associated with the development of cirrhosis. Okay, so yun yung delikado. So ibig sabihin, hindi lang pala yung mga patients na nag-alcohol or yung patients na may chronic viral hepatitis, yung nag-develop ng cirrhosis, pwede mag-develop ng liver cirrhosis yung mga patients na obese. Okay? And syempre, we also have cardiac cirrhosis sa cause of HB core, HBE, antigen and anti-HBe. Okay? So, yung commonly na nakikita ninyo sa clinics or sa wards, for example, sa wards, kung ang lagi ko nakikita dyan, madalas is chronic Hep B with low infectivity or chronic Hep B with high infectivity. Na yung differentiating factor lang ng high infectivity sa low infectivity is, so pag sinabing, ang nag-determine kasi ng kung high or low infectivity is kung the presence of HBeAg. So tingnan mo to, HBeAg is positive, positive siya in patients na may high infectivity. Okay? If the patient has negative HBeAg, kasi nga, positive yung anti-HBe, so kung negative siya dito, tapos positive siya sa anti-HBe, low infectivity. So what determines infectivity is yung presence of HBe antigen. Okay? And then, aralin nyo na lang itong mga susunod na other serologic patterns para malaman nyo rin kung ano yung interpretation nila. Okay? So other causes of cirrhosis, maliban sa chronic viral hepatitis and sa alcoholic hepatitis, alcoholic na cause is autoimmune hepatitis. Ito yung autoimmune hepatitis, ito yung mga hepatitis na may positive yung ENA, no? And anti-smooth muscle antibodies, no? And then we also have NASH or non-alcoholic steatohepatitis. Ito yung pwedeng endpoint ng mga patients may NAFLD or non-alcoholic fatty liver disease. They can go on and develop non-alcoholic steatohepatitis, which is then associated with the development of cirrhosis. Okay, so yun yung delikado. So ibig sabihin, hindi lang pala yung mga patients na nag-alcohol or yung patients na may chronic viral hepatitis, yung nag-develop ng cirrhosis. Pwede mag-develop ng liver cirrhosis yung mga patients na obese. Okay? And syempre, we also have cardiac cirrhosis as a cause of cirrhosis from patients with long-standing right-sided heart failure. Kasi syempre, from the right side of the heart, papuntang IVC, nakakonect yan sa liver, di ba? So, in patients with cirrhosis, we have to know kung yung patient ba may portal hypertension. Kasi yan yung mag-determine no, kung yung patient ay pwede magkaroon ng iba nating complications of cirrhosis such as yung esophageal varices. So, yung patient with cirrhosis pwede magkaroon ng portal hypertension. Portal hypertension is defined as a hepatic venous pressure gradient or HVPG of more than 5. Okay? So ito yung mga causes ng portal hypertension is dahil sa resistance to the passage of blood through the liver, dahil nga may mga regenerative nodules na micronodular if alcoholic, or pag in-stop mo yung micro and macronodular nodules dahil doon nagkakaroon ng resistance to the passage of blood through the liver kasi hindi na smooth yung arrangement ng cells ng hepatocellular yung mga liver cells hindi na ganun kaganda yung kanilang anatomic structure yung anatomic structure. So dahil nga sa regenerative nodules nagkakaroon ng intrahepatic resistance, so nagkakaroon ng portal hypertension. Number two cause ng portal hypertension is increased splanchnic blood flow. That's vasodilation within the splanchnic vascular bed. Ibig sabihin, increase na nga yung resistance doon sa liver, hindi na mapapas yung blood from the portal vein papunta sa liver. Di ba yung portal vein ang nag-drain ng lahat ng blood sa GI? So yung GI, di ba yung splanchnic na circulation? So ibig sabihin, may resistance na nga doon, maluwag pa doon sa likod. So may resistance na nga papunta pa-forward, maluwag pa sa likod. So saan pupunta yung blood? Doon sa doon sa saan maluwag, di ba? And hindi sila pupunta sa may resistance papunta portal vein. So dahil excuse me. So dahil may vasodilation sa splanchnic circulation. So kaya hindi bumabalik yung blood pupunta sa IVC. So nag-iipon sila sa splanchnic circulation. So nagkakaroon ng iba't ibang complications ng portal hypertension. So pwede magkaroon ng variceal hemorrhage dahil nagkaroon ng esophageal varices, ascites, and hypersplenism. Kasi di ba before mag-portal vein, nakakonect sa splenic vein, sa inferior and superior mesenteric vein. So lahat yung nakakonect yan ay. So pag nag-backflow yung blood pupunta sa mga veins na sinabi ko, nagkaroon ng variceal hemorrhage, ascites, and hypersplenism. Okay? So as I mentioned kanina, the first indication of portal hypertension is thrombocytopenia. So it's usually heralded by thrombocytopenia, portal hypertension. And what you will see on abdominal imaging in patients with portal hypertension is nodular liver and intra-abdominal collateral circulation. Kasi nag-open up yung mga collateral circulation kasi nga may resistance dun sa liver from the portal vein. Portal vein, puntang liver, dahil nga may nodules and may cirrhosis, hindi na maka-forward. So may resistance. So ano yung treatment natin sa variceal hemorrhage? Well, primary prophylaxis, ibig sabihin hindi pa nangyayari yung bleeding, kailangan natin silang i-monitor by routine screening, by endoscopy of all patients with cirrhosis. Kailangan i-screen sila by endoscopy. Titingnan kung may mga possible na pwedeng mag-bleed na varices. And gumagamit din tayo ng non-selective beta blockade in the form of propranolol. Kaya nyo makikita yung mga patients with cirrhosis, may propranolol sila na maintenance. Or variceal band ligation or EVL or esophageal variceal ligation. No? Now, pag nag-bleed na yung patient, for example, hindi nakita na may esophageal varices, nag-bleed. Okay. So ang gagawin natin, we use vasoconstricting agents na discuss natin kanina, pwedeng terlipressin or octreotide. And then repeated EVL until varices, EVL or esophageal variceal ligation, and repeated EVL until varices are obliterated. And then kung after endoscopic medical therapy as we discussed kanina, we can go to tips. Okay? Yung patient with cirrhosis, may splenomegaly din, dahil nga dun sa sinabi ko, sa pwedeng consequence siya ng portal hypertension. So it's congested in nature, enlarged spleen, kaya nagkaroon ng thrombocytopenia, usually requires no specific treatment naman ang splenomegaly. Okay? Another complication is ascites, no? Dahil sa portal hypertension din, as you can see here, dahil sa cirrhosis, nagkaroon ng portal hypertension and splanchnic vasodilation. So may resistance na nga pupunta dun sa liver. So yung blood na nandun sa portal vein, pupunta sana sa liver, pero hindi mapunta dun, so babalik sila sa splanchnic circulation. Maluwag din dun sa splanchnic circulation kasi may splanchnic vasodilation. No? So dahil sa splanchnic vasodilation, marami yung blood na nandun sa splanchnic circulation. Yung blood na dapat nasa systemic circulation ay nasa splanchnic circulation. Yung blood so konti na lang yung blood na nasa systemic circulation. So dahil konti lang yung blood na nasa systemic circulation, sasabihin ng kidneys, konti yung blood na nasa systemic circulation natin. So yun yung tinatawag na arterial underfilling. So dahil konti lang yung blood na napupunta sa systemic circulation, madidetect yun ng kidneys na kulang yung blood. So magre-retention of fluids and sodium. So magkaroon sodium retention, eventual plasma volume expansion, and then eventually perform na ascites. Tapos dahil nga naiipon yung blood sa splanchnic circulation, tataas yung splanchnic pressure and eventually magkaroon din ng formation of ascites. Okay? So konektado lahat yan. So, anong clinical manifestations of ascites? Well, malaki yung chan dahil sa tubig, hindi makahinga dahil napupush up yung diaphragm, shortness of breath, and on examination, you will see bulging flanks, fluid wave, positive fluid wave, and positive shifting dullness dahil sa tubig na present. And then in the evaluation of patients with ascites, you have to do paracentesis. Okay? Now, in patients, pagkatapos mo mag-paracentesis, you have to measure, makikita mo rin natin later, in patients with ascites, you have to measure yung SAAG, or yung serum ascites albumin gradient. Baling gagawin mo, kukuha ka ng serum albumin at the same time na ikaw ay magpa-paracentesis kung saan ikaw ay kukuha naman ng acetic albumin. So serum albumin ang kukunin mo. And then kukuha ka rin sa dugo and then kukuha ka rin ng acetic albumin dun sa ipaparacentesis mo. And then pagmamay na sila. Pag ang result nila is more than 1.1 grams per DL, most likely yung ascites na is dahil sa cirrhosis. So bakit natin kailangan i-determine? Kasi kung if the SAAG is less than 1, most likely, no, infectious or malignant cause yung ascites mo. Pwedeng TB peritonitis, or malignant ascites. So yun yung most likely causes ng less than 1 na SAAG. Okay? Kasi hindi lang naman cirrhosis yung pwedeng cause ng ascites. Okay? So in terms of treatment ng ascites from cirrhosis, dietary sodium restriction, pwede natin initial na gawin, less than 2 grams na, limit lang natin yun. Pero kung hindi nag-work yun, or for example, moderate ang amounts of ascites, you can start already with furospiro. So yung furosemide spironolactone na combination. So kailangan niyo laging i-maintain, no? Kailangan niyo laging i-maintain yung ratio ng furospiro na 2:5. So, Furospiro na 2:5 yan yung meeting. So, Furosemide 40 and Spiro na Lacton 100. So, ang ratio nun is 2:5, diba? So, pwedeng Furo 40, Spiro 100, or Furo 80, Spiro 200, up to a max of Furo 160, Spiro, up to a maximum of 600 for Spiro and then Furosemide na 160. Pero you have to always maintain yung ratio na 2:5. And then, kunwari, nag-meds ka na, dietary sodium restriction ka na, and then nag-Furospiro combination ka na, ang ratio is 2:5. Pag hindi pa nag-respond yung ascites, ang tawag na is refractory ascites. In those cases, you have to do repeated LVP or large volume paracentesis. Magtatanggal ka lang ng tubig sa tiyan, ulit-ulit. Okay? Repeated LVP. Now, there's another complication of cirrhosis that's called hepatorenal syndrome. So, yung patients with hepatorenal syndrome, ibig sabihin nito, may cirrhosis talaga siya, pero naapektuhan nila yung kidney. Yung kidney, wala talagang problema. Wala siyang structural problem. Functional, yung renal failure, without renal pathology. Okay? So, paano mo i-diagnose yung patient to have hepatorenal syndrome? Patient, in the background of a patient with cirrhosis, dapat yung patient na is may large volume of ascites, so malaki ng tiyan, puro tubig, and at the same time, stepwise yung increase ng creatinine. Kuha yung araw to, yung creatinine after a few days, pataas, tapos malaki yung tiyan niya with ascites. So, syempre, no other causes of increasing urea. Yung patient, na-exclude mo yung other causes of acute renal failure, no? Pwede mo sabihin na yung patient hepatorenal syndrome. So, ano yung treatment for hepatorenal syndrome? Pinag-try octreotide, IV albumin, or the best. Pero pag ang tinanong sa exam is best therapy, liver transplant. Okay? So, another complication of cirrhosis is hep-NSF. Okay? In patients with hepatic encephalopathy, ito yung mga patients may altered mental status and cognitive function. Okay? Occurring in the presence of liver failure. So, ano yung mga symptoms nila? Yung mga symptoms nila is confusion, personality change, asterixis, yung pag binento mo yung kamay, tapos binitawan mo, mag-liver flap siya. Okay? Pero the most severe complication of hep-NSF is cerebral herniation. Okay? So, ano yung reason for having hep-NSF? It's gut-derived neurotoxins na hindi na-remove ng liver kasi nga sila na decrease ng hepatocellular mass niya. So, maliban sa gut-derived neurotoxins, the ammonia is typically elevated. So, that's one of the causes of hep-NSF, yung naiipon na ammonia in patients with cirrhosis. Okay? Pero, kahit na tumataas yung ammonia, tandaan niyo, hindi tayo nag-measure ng serum ammonia in patients with cirrhosis and hep-NSF. May mga doctors na ganun. Okay? So, you must not make that mistake. In a patient with cirrhosis and hep-NSF, nag-request sila ng serum ammonia. Ang sabihin ko ngayon, wala siyang information na ibibigay sa'yo additional. Additional lang siyang gastos sa pasyente. Pero wala siyang ibibigay sa'yo ng additional information. Kasi nga, yung ammonia, yes, mataas siya, pero hindi siya correlated with severity. I mean, nag-request ka, ano gagawin mo kasi, diba? So, wala siyang value. So, huwag mo na-request, nagsasayang ka ng pera. So, paano mo ma-determine na malala yung hep-NSF? Clinically, kung may confusion, personality change, ganyan. Pero ammonia is wala siyang bearing, okay? So, ano yung mga precipitating factors ng hep-NSF? Ang isa dyan, na mahalaga nyo malaman, is infection. In a patient, for example, may ascites and may fever and sakit yung tiyan, na pwedeng yung ascites niya is nag-SBP na, spontaneous bacterial peritonitis. Yung spontaneous bacterial peritonitis dahil infection yun, pwede mag-precipitate ng hep-NSF. Pwedeng yung patient, malaki yung tiyan, nag-fever, nagpunta sa ER dahil hindi na makausap, tutulog-tulog. So, ibig sabihin may SBP siya, spontaneous bacterial peritonitis infection, nag-precipitate ng hep-NSF kaya tutulog-tulog in a patient with cirrhosis. So, that's one precipitating factor of hep-NSF infection. Another thing is hypokalemia. That's the reason kung bakit kailangan natin monitor ng mga electrolytes in patients with cirrhosis kasi pwede siyang precipitate ng hep-NSF. So, paano ang hypokalemia? Nagka-precipitate ng hep-NSF kasi nga hypokalemia, tandaan niyo, ang mechanism nun is ang hypokalemia nag-lead siya sa increased renal ammonia production. Hypokalemia leads to increased renal ammonia production. Okay? Dahil sa increased renal ammonia production, yung ammonia na yun pumunta sa utak, nag-precipitate ng hep-NSF. Okay? Pero even if that's the case, you still should not request for serum ammonia in patients with cirrhosis. So the diagnosis for cirrhosis is for hep-NSF is clinical, as I mentioned kanina. So how do we treat hep-NSF? Lactulose. Okay, bakit? Kasi ang ginagawa ng lactulose, ina-acidify niya yung colon, leading to elimination of nitrogenous products in the gut. For example, di ba sabi natin, pag mataas yung ammonia na pumupunta sa brain, nagkakaroon ng hep-NSF, di ba? So what happens is, yung ammonia, di ba, is NH3. Pag dinagdagan mo siya, pag inacidify mo siya, using lactulose, if inacidify mo yung NH3 ammonia, using lactulose, if you acidify that, yung NH3 maging NH4+. Yung NH4+ na yun, polar na siya, di ba? Ibig sabihin, hindi na siya magkukross sa mga cell membranes ng gut mucosa, sa cell membranes ng gut mucosa kasi polar na siya, hindi na siya magkukross sa mga cell membranes. So doon na siya matatrap na siya. Dahil polar na siya, matatrap na siya within the gut lumen kasi nga na-acidify mo siya from ammonia to NH3, from NH3 ammonia to NH4+ ammonium. Yung ammonium na yun, charged na siya, polar na siya, matatrap na siya sa gut lumen kasi hindi siya magkukross sa mga membranes, and then idudumi mo na ang ammonia. So mababawasan yung ammonia, mababawasan na yung hep-NSF niya. Okay? So that's yung tinatawag na elimination of nitrogenous products in the gut using lactulose. So kaya napaka-effective na lactulose. So, after we discuss lahat, before tayo pumunta ng infectious diseases, sasabihin ko muna, para hindi ninyo malimutan yung mga management in cirrhosis, kailangan kasi in patients with cirrhosis, wala kayong malimutan na management. Okay? So, dyan papasok yung mnemonic ko na vibes. Okay? So, yung mnemonic na vibes is wait lang. Vibes. Okay. So, yung V is for volume. Tandaan nyo, volume. Ibig sabihin, in patients with cirrhosis, you have to manage volume. You have to give Furospiro in in patients with moderate amount of ascites in the ratio of 2:5. Ano pa is volume? In patients with bipedal edema, you can also, nabigyan mo ng Furospiro, so mapapaihip mo na sila. So, mababawasan mo yung volume sa katawan. In patients with small amounts of ascites, you can give sodium restriction, less than 2 grams per day. Next is, para hindi wala kang malimutan, sa management ng patients na may cirrhosis, infection. So, tingnan mo yung ascites niya, kapain mo, kung may tenderness ba, at may fever siya, kasi hindi naman lahat ng patients na may SBP, na patients na may ascites na naging spontaneous bacterial peritonitis, hindi lahat ay may abdominal tenderness. Yung iba, fever lang. Pag patient may fever, may abdominal tenderness, it could be an infection of the ascites, of the acidic fluid. So, ang gagawin mo, bibigyan ng antibiotics sa mga patients may spontaneous bacterial peritonitis, bibigyan natin ng antibiotics sa mga patients may spontaneous bacterial peritonitis is third generation cephalosporins, pwedeng in form of cefotaxime or ceftriaxone. And then, maliban sa infection, kasi at saka isa pa, infection kasi pwedeng precipitate ng hep-NSF, kaya alam siya i-treat. Next, is bleeding, no? Ang B. Bleeding. Sabihin, tingnan mo kung may, mag-DR ka, tingnan mo kung merong, may black tarry stools, parang kulay ng dumi niya, or kung may, hemorrhoids, or tingnan mo kung may bleeding sa bibig, or any site of bleeding kasi nga di ba prolong yung prothrombin time, or kung may kung naka-NGT tingnan mo kung ano yung output kung may bleeding kasi baka may esophageal varices na sila. Okay? Next is NSF. Ang E is NSF. So, anong treatment natin sa NSF? Lactulose. Kasi you have to acidify the colon to remove the ammonia and other nitrogenous products in the gut. May dumi mo sila. Hindi na sila pumunta sa utak and mag-precipitate ng NSF. Last is S. S is for screening. Sorry, sulat ko. Screening, tapos yung sa surgery. Okay? Screening, ay sabihin ng S is screening. Screening for hepatitis, chronic hep C. So, magre-request ka ng hep profile para makita kung saan galing yung cirrhosis niya. Baka pala chronic hep C siya or chronic hep B. No? Tingnan mo yung serological patterns. Malaman mo kung ano interpretation, chronic hep B with low or high effectivity or chronic hep C. Ano pa? Sa screening, screening for, kung may chronic hep B siya, screening for malignancy. Kasi nga, ang chronic hep C or chronic hep B, they can both lead to hepatocellular carcinoma. So, ang screening doon is ultrasound. No? Ano pa? Surgery ay yung sa for possible transplantation. Pwede mo siya i-list sa, in an ideal setting, pwede mo siya i-list sa for possible liver transplantation. Go to infectious diseases, for this case. We have tatlong cases. So, 33 female. The first is a 33 female presenting with pain on urination and frequency for a few days with no comorbid with negative PT. The next one is a 35 female with low back pain, nausea, vomiting, and fever. Surgery ay yung sa for possible transplantation. Pwede mo siya i-list sa, in an ideal setting, pwede mo siya i-list sa for possible liver transplantation. Go to infectious diseases, for this case. We have tatlong cases. So, 33 female. The first is a 33 female presenting with pain on urination and frequency for a few days with no comorbid with negative PT. The next one is a 35 female with low back pain, nausea, vomiting, and fever. No comorbid negative PT. And then the next one is a 68 male with increased sleeping time because of fever, non-diabetic and hypertension with right-sided residual with hypogastric tenderness, urea, mild hematuria on urinalysis. So dito pa lang, no, makikita nyo na ang yung complaint ng patient na urination frequency for a few days, okay, yun pa lang, pwede nyo na i-diagnose yung patient as having UTI without the benefit of urinalysis, no? So, especially sa non-pregnant na female tulad nito kasi negative siya. And then, this one may fever. So, wala siyang lower UTI symptoms such as urinary pain on urination, dysuria and frequency, pero meron siyang acute low back pain, nausea, and fever. So, yung fever pa lang na yun. So, pwedeng mo na actually tawagin na you can consider the patient to have acute pyelonephritis, no? Sa isang non-pregnant patient. And then, for this one, you can call this complicated UTI. Complicated UTI kasi may pyuria and mild hematuria on urinalysis. May hypogastric tenderness, so pwede mo sabihin na UTI yun. Complicated siya kasi the patient has diabetes, okay? And fever. So, we will see later, sabi ko lang yung diagnosis. We will see later kung bakit sila ay diagnosis. Ang diagnosis nila ay UTI. So, ano ba yung UTI? It encompasses a right to connectivity, pwedeng asymptomatic bacteriuria, cystitis, pyelonephritis, or prostatitis. More common siya sa females kasi syempre shorter yung distance between the urethra and the anus, where urine pathogens usually enter gram-negative rods migrate to the urinary tract. So, tatlo yung kailangan consider na factors in the development of UTI. So, we have the organism itself, kung ano yung virulence factors na present sa kanya. Sa host, ano yung mga underlying diseases niya, behavioral factors and genetic background. And sa environment naman, yung vaginal ecology, anatomy urinary, if the patient is having urinary retention. So, the first disease entity is asymptomatic bacteriuria. So, how do we diagnose asymptomatic bacteriuria? So, ibig sabihin asymptomatic bacteriuria is wala siyang symptoms, pero may presence of bacteria sa urine. So, in asymptomatic na women, ang ginagawa natin is dalawang consecutive na voided urine specimen with the same isolate na isolate na sa urine, na ang CFU niya is more than 100,000 CFU per ml. Sa men naman, wala symptoms, isa lang, a single, clean catch, voided specimen with one species isolated more than equal 100,000 CFU per ml. Yun yung dami ng bacteria naman sa igit. Sa mga catheterized patients naman, one species isolated na more than equal 100 CFU per ml. So, mas mababa yung threshold no, sa mga catheterized patients. More than equal 100 CFU per ml lang na single catheterized specimen, pwede man tawagin na asymptomatic bacteriuria. So, question. Lahat ba ng patients na may asymptomatic, lahat ba ng patients kailangan i-screen and i-treat na for asymptomatic bacteriuria? Like, the answer is no. Okay? We have only certain patient populations na kailangan mo i-screen and i-treat for asymptomatic bacteriuria. So, ano yung mga patient population? Yung mga pregnant women, i-screen mo yan for ASB. Those who will undergo GU manipulation or instrumentation. Those na may neutropenia, part of an infection control plant managed cluster infections unit, and those na may high incidence of bacteremia in their institution. Okay? So, ang mahalaga dyan is yung pregnant women, those who will undergo GU manipulation instrumentation, those na may neutropenia. Okay? So, hindi ka nag-screen for ASB in those patients na healthy, patients na may DM, elderly, patients na may indwelling catheters, transplant patients, HIV, spinal cord injury, or urological anomalies. We do not screen for ASB in those patients. Okay? So, what do we use to screen for ASB? Urine culture. Okay? Kung wala namang facilities na walang urine culture, you can replace that with kung yung urine na yung urine GS niya is may significant pyuria more than 10 per high power field or as positive gram stain of unspan urine in 2 consecutive midstream urine samples. May mga kasi institutions na walang urine culture pero may urine GS. Okay? So, in a patient with asymptomatic bacteriuria, so yun nga yung diagnosis nga natin is itong tatlong itong tables na to. Ang treatment natin is for 7 days. Okay? So, for 7 days, as you can see here, dapat it's asymptomatic muna. So, itinan mo yung questions. Pregnant, about to undergo GU instrumentation or manipulation. Kasi sila lang naman dapat mag-screen for ASB. So, kung wala naman silang symptoms and hindi naman sila itong patient population na to, no need to screen or to treat. Pero kung may either of these populations yung patient mo, or yun nga yung patient ng neutropenia, you have to screen for ASB with urine culture, and then based on the urine culture, yung ibibigyan natin ng gamot, usually for 7 days. Okay? So, ito yung mga antibiotics that can be used for asymptomatic bacteriuria in pregnancy. Okay? Ito yung mga options natin. Pero tandaan mo, yung mga options na nandito, ay lahat ay FDA risk category B for pregnant women. Isa lang yung C dito, yung TMPSMX. Okay? You have to avoid that in first and third trimester. So, next disease entity is AUC or acute uncomplicated cystitis. So, typical patient na may ganito is pre-menopausal non-pregnant woman. Excuse me. Na may acute dysuria, frequency, urgency, and gross hematuria. Okay? As I said kanina, in patients with acute uncomplicated cystitis, urinalysis is not necessary. No? In women with one or more of the above symptoms, basta yung patient is may dysuria or frequency or urgency or gross hematuria, kahit isa lang doon, hindi mo na kailangan ng urinalysis in a population of non-pregnant women. Kasi nga, lalo't higit na, no? So, yun yung mga kailangan i-consider ha. Dapat non-pregnant woman. Tapos ay yun nga, ito yung mga symptoms kahit isa lang dyan. And most especially with the absence of vaginal discharge and complicating conditions. So, dapat wala siya niyan. Para masabi mo na yung kanyang UTI is AUC or acute uncomplicated cystitis. Bakit? Kasi kung yan ay may presence of vaginal discharge, ito ang hindi UTI sasabihin mo. Sasabihin mo, yung patient is may STI. Tapos kung yung patient naman may complicated conditions, sabihin mo is complicated UTI. Okay? So, UNCS is not recommended. And yung mga makikita mo sa urinalysis na dipstick LE or yolk esterase and nitrite test, they are not prerequisites para i-treat mo yung patient for UTI. So, ano ba yung mga conditions magsasabi na complicated yung UTI mo at hindi siya yung itong acute uncomplicated? So, the conditions that define a complicated UTI is the following. So, doon sa patient natin kanina na nag-stroke na siya, di ba? Nag-stroke na siya sabi, yung third patient, and by diabetes, yan. So, pwede mo sabihin na complicated yung UTI niya. Isa pa, yung patient is male, di ba? Dalawang female yun, and then yung third one is male, na nag-stroke. So, yun, male and diabetic. So, yun yung magsabi sa'yo na yung patient is may complicated UTI. Okay. The most cost-effective approach, hindi na kailangan ng urinalysis or urine CS in the patient with AUC, is empiric antibiotic treatment. Walang CS, no? So, it's the most cost-effective approach. So, ito yung mga antibiotics na pwede mong pagpilian. Okay? So, as you can see here, ang primary natin na choices ay nitrofurantoin and fosfomycin. Ang maganda sa fosfomycin, very high efficacy siya, tsaka convenient siya kasi single dose lang siya. Sa sachet lang siya, titimpay mo ng tubig, inumin ng patient. Single dose lang siya and low propensity for collateral damage. Ibig sabihin, wala kang mapapatay na ibang, for example, yung mga beneficial na bacteria, for example, is yung lactobacilli, no? Na nasa vaginal environment. So, good din yung fosfomycin against MDR or multi-drug resistant uropathogens, and minimal din yung kanyang side effects. Okay? So, bakit yung kung may mapapansin nyo, yung mga quinolones, nandito sila sa alternative choices? Kasi hindi ka dapat mag-first line, hindi dapat sila yung primary agent mo sa pagtreat ng UTI. Kasi, efficacious itong mga quinolones ito, pero may high propensity kasi for collateral damage. Pwede kang may eradicate na ibang bacteria, hindi mo lang kailangan i-eradicate. Okay? And hindi mo na siya magagamit. For example, yung patient may UTI, tapos biglang may TB siya sa next month, nagkaroon siya ng tuberculosis. Hindi mo na siya, tapos ay resistant pala, MDR-TB pala yung kanyang TB. Eh, hindi mo na magagamit yung quinolones as second line sa mga patients na may MDR-TB, di ba? So, mas maganda i-reserve for those cases. So, ito yung nakita natin na algorithm. So, this is from yung guidelines, Philippine guidelines for UTI. in acute uncomplicated cystitis, otherwise healthy, in patients na otherwise healthy, walang definition para masabi na walang diseases or disorders na will define complicated UTI. So otherwise healthy na elderly women with AUC or acute uncomplicated cystitis, the recommended duration is the same as with the general population. Okay? And next question, kung hindi natin kailangan ng urine CS to diagnose UTI, hindi natin kailangan ng urine CS or urine analysis to confirm na nag-resolve na yung UTI. Routine post-treatment urine CS and urine analysis are not recommended. So ito yung algorithm natin, healthy non-pregnant women with dysuria, frequency, urgency, or hematuria, you can treat empirically with recommended oral antibiotics as I showed on the previous slide. Reassess at the end of therapy. Pag ibig sabihin na reassess dyan is clinically mo siyang i-reassess, hindi mo siya ikukunan ng urine CS or urine analysis. Okay? Pag nag-resolve, no further treatment. Pag hindi nag-resolve, for example, may hematuria pa rin, may dysuria pa rin, you can do urine analysis, urine CS, and maybe change antibiotics. Okay? So yun nga, yung next patient natin dun sa first slide natin kanina sa UTI ay yung patient na yun may fever. Wala siyang lower UTI symptoms pero may fever siya and acute low back pain. So pwede natin siyang tawagin as acute uncomplicated pyelonephritis or AUP. So nangyayari yung typical patient with AUP is otherwise healthy women na walang clinical historical evidence of anatomic or functional urologic abnormalities kasi otherwise tatawagin siyang complicated UTI, okay? Or complicated pyelonephritis. The classic syndrome is fever, chills, flank pain, CVA tenderness, nausea and vomiting. Hindi ba nasabi natin kanina? Plus or minus signs or symptoms of lower UTI. So yung patient natin na wala siyang signs or symptoms of UTI, meron na siyang acute low back pain and fever. What differentiates lower UTI sa upper UTI or cystitis from pyelonephritis? What differentiates them is fever, okay? So diagnostic tests sa AUP unlike sa AUC ay sa AUP kumukuha tayo ng urine analysis and gram stain. They are both recommended. Unlike sa AUC na hindi sila recommended, pwede ka mag-empiric treatment agad. So sa pyuria, usually makita mo more than equal 5 white WBC per high power field o centrifuged urine. Urine CS should be routinely performed for cost-effective, safe and appropriate antibiotic use. So kailangan mag-CS para malaman kung ano antibiotic yung bibigay mo. Pero blood cultures kahit may fever in patient are not routinely recommended. Pero if the patient presents with sepsis, kunwari bumabagsak na yung BP, toxic looking, no? Ibig sabihin ay mataas yung fever, mabilis yung hinga, tapos tachycardic. So kung ganun yung issue ng patient, you can opt to do blood cultures. Biomarkers, Procal and CRP are not recommended. Pwede ka actually mag-treat ng AUP on an outpatient basis. Pero may mga indications tayo for admissions ng patients may AUP. Those that are unable to maintain oral hydration or take meds. For example, yung siguro elderly woman na malabo yung mata, tapos concern sa pag-comply adherence. Ibig sabihin yung mga, for example, yung mga patients na walang pambili or malayo, taga-isla, ganyan. So, may hirapan mag-adhere or mag-comply kasi syempre yung kanilang pambili sana ng gamot, pambili na lang, pamasahin na nila pa uwi. Presence of possible complicating conditions. Diba? So, indication for admission yan. Kung yung patient is, for example, ng kidney stone, pero hindi confirmed. So, possible pa lang, totoo yung sinabi niya na may kidney stone siya, kasi syempre hindi natin confirm pa. Pag gano'n, you can admit the patient or patients with severe illness. Yung sinabi ko, high fever, severe pain, signs of sepsis. So, ito yung empiric treatment natin for acute uncomplicated pyelonephritis. Okay? So, dito, gumagamit na agad tayo as primary yung mga fluoroquinolones, mga Cipro, Levo, at ofloxacin. Okay? Now, tandaan nyo, in patients na hindi nag-require ng hospital admission, for example, yun nga, kaya nyo ng kanya, kaya nyo mag-comply, mag-adhere, pwede kayo magbigay ng initial, isang single dose of IV or IM dose of triaxone, pwede nyo i-consider yun. Bigyan nyo lang siya ng 1 dose of Ceftri or IM or IV and then yung mga susunod is puro oral na lang ng antibiotics. Pero yun yung mga patients na hindi septic ha. So, yung routine urologic evaluation or routine use of imaging procedures in patients with AUP are not recommended. Okay, tandaan niyo yun. Hindi lahat ng may AUP kailangan niyo i-ultrasound or CT or mag-helical CT to look for stones. Hindi siya recommended. Meron tayong certain population ng patients na kailangan nating na radiologic evaluation. Yun yung mga patients with history of urolithiasis. Yun yung pH more than equal 7.0, which will tell us na baka may kidney stone siya or renal insufficiency, mataas ang CREA for example, or may oliguria. Okay. Kung wala naman siyang ganito, yung patients na sinasabi natin, pwede rin tayong mag-radio evaluation if the patient, after magbigay ng ciprofloxacin or levofloxacin, ay may fever pa din after 72 hours of treatment or nag-recur yung kanyang symptoms. So, bakit tayo mag-radio evaluation? Kasi siguro, kaya siya ay despite antibiotics, ay may fever pa rin kasi there could be a focus of infection within the urinary tract. Pwede may nephrolithiasis, may UTO or urinary tract obstruction from a nephrolithiasis, pwede may abscess, no? Isang clue para malaman mo na baka may perinephric abscess yung patient based sa urine GS, kahit hindi mo na-maintain, for example, yung urine CS. Isang clue is kung may nakita kang polymicrobial infection, okay, or other complications of pyelonephritis. Refer to urology if abnormalities are identified in imaging. Para for example, kung may perinephric abscess, yung uro, sila yung mag-excise no abscess na yun, mag-remove ng abscess. So this is a algorithm from the Philippine CPG nga for the treatment or the management of AUP or acute complicated pyelonephritis. No, so if the patient is nasabi mo na may AUP siya, you have to assess the severity and illness and likelihood of adherence to treatment as we mentioned kanina. If the patient is too septic siya, punta ka dito sa yes, admit mo yung patient, mag-urine analysis ka, urine GS, blood CS, if septic din, magbagsak ang BP, high fever, severe pain, and then start empiric IV antibiotics. And then, assess the patient within 72 hours. Kung may fever pa din, shift to another antibiotic, continue antibiotics for, kung nag-improve yung symptoms, you can shift the antibiotics to oral and then continue the antibiotics for 10 to 14 days. And then, pag naman hindi nag-improve yung symptoms within 72 hours, no, you can repeat the urine CS, consider for radiologic evaluation, CT or ultrasound, and then consider urologic evaluation. Okay? If naman yung patient is hindi septic, hindi siya septic, you can do urine GS pa din, kasi nga AUP siya. Treat as outpatient, yung nga sabi ko sa inyo, pwede natin siyang bigyan ng 1 dose lang of IV or IM as triaxone, and the rest is oral antibiotics na lang. And then yung oral antibiotics na yun should be based on gram stain results. Okay? So sabi ko nga rin, case of this AUC, AUP, and it's complicated UTI. Okay? So next case natin is a case of typhoid fever. Sorry. A 36 female who presented with 1 week history of fever, malaise, abdominal pain, and diarrhea. Brought to the ER for persistent nausea and vomiting with no known comorbids, direct epigastric pain, mataas yung fever, 39.6. Okay, ito yung notable dito ha. Sorry na i-reveal ko na yung diagnosis, pero ito yung notable dito, tingnan niyo. Fever, 39.6. Pero despite the fever, hindi siya tachycardic, 56 lang. Diba? So yun yung tinatawag natin na temperature pulse dissociation. Okay? So may particular diagnosis lang or particular diseases lang. Pwede mag-present with that, no? And one of those is typhoid fever. Okay? Sabihin, imbes na tachycardic din siya, pag may fever, siya ay bradycardic, no? temperature pulse dissociation. So, as you can see here, no, may direct epigastric tenderness na. Yung isa pang giveaway dito, yung skin exam niya showed faint flesh-colored blanching macular rashes on her trunk. Okay? So, dun pala napapaisip ka na, baka, ano siya, typhoid fever. Okay? Kasi, ano yung faint flesh-colored na yun? Yung mga rose spots na. Okay? So, on typhoid fever, systemic disease, characterized by fever, abdominal pain, katulad ng meron yung patient natin. And ang typical patient na to is any individual who lives in or has history of travel from tropical and subtropical areas, presenting with fever na more than 38 degrees Celsius for more than equal 5 days. Tandaan niyo yung araw, ha? Yung duration, more than equal 5 days, more than 38 degrees. This is the most prominent na sign with any of the following. Okay? So, sa early PE findings, as you can see, ito yung description ng rashes ng sa patient natin, no? Faint, salmon-colored, blanching, MP rashes or maculopapular rashes. Excuse me. Usually nakikita siya sa trunk and chest, and evident siya at the end of the first week and results without trace. Okay? Actually, pag binayos niyo siya, you can culture salmonella from it. And then on other PE findings, hepatosplenomegaly, epistaxis, and sabi ko kanina, relative bradycardia at the peak of high fever. Complications, GI bleeding and intestinal perforation, no? Which usually nag-occur, itong GI complications na to, na GI bleeding and intestinal perforation, usually nag-occur yan 3rd to 4th week of illness. Okay? So, it results from the hyperplasia and ulceration and necrosis of the ileocecal na Peyer's patches at the initial site of salmonella infection. So, doon siya unang nag-infect sa Peyer's patches, sa ileum. Okay? In order to confirm, there are two methods, pwedeng direct detection and indirect detection. Yung alam natin, yung tinuturo sa atin siguro ng pre-med, sa amin, ng pre-med namin, may tinuturo pa na indirect test, which is the Vidal test, pero it's no longer recommended at this time, no, for the diagnosis of typhoid fever. So, outdated na yung knowledge na yun. So, in order to treat typhoid fever, ito yung mga options natin, no. We can go with amoxicillin, chloramphenicol, no, TMPSMX, Cefixime, azithromycin, cipro, and ofloxacin. So, depende sa kung binigyan mo, yung duration niya, okay? You have to take note din of the side effects. Siyempre, sa chloramphenicol, we have myelosuppression, and sa, dahil may sulfa drug sa TMPSMX, pwede magkaroon ng SJS, okay? Take note na lahat ng medicine nandito sa uncomplicated typhoid fever ay oral. Okay? As opposed sa kung yan ay complicated typhoid fever, so lahat yan is IV. Pero eventually, pwede ka mag-step down naman sa mga oral. Tapos, di ba, dito puro 7 days, dito puro 14 days. Actually, dito sa complicated typhoid fever, halos magkapareha sila ng duration. Tingnan nyo yung azithromycin, 7 days dyan. Dito, 7 days din. Diba? 7 days. And then dito, 7 days din. Okay? So, magkapareha sila ng duration. And then, so that's the for uncomplicated and complicated. We also have MDRTF or multi-drug resistant typhoid fever. So, yan ay para sa mga, so pag sabi MDRTF, yun yung mga strains na resistant to first-line drugs. Chloramphenicol, ampicillin, saka TMPSMX. So, kailan ka suspect na yung patient may MDRTF? Pag nagbigay ka ng antibiotics, pero after 5 to 7 days of the first-line treatment, hindi pa siya nag-respond. Fever pa rin, diarrhea, abdominal pain. Tapos, lalo na kung siya ay nagkaroon pala ng household contact on history sa mga documented cases ng MDRTF. Kung dun sa place nila, ay may epidemic na MDRTF. And kung magkaroon siya ng clinical deterioration or development complications. Yung complication nga natin is GI bleeding and perforation. As we mentioned kanina, nag-occur on the 3rd or 4th week of illness. So, ito yung mga antibiotics that we can choose from. Okay, next patient, a 45 male with high-grade fever, muscle aches, abdominal pain, and decreasing urine output. Okay, may clue na naman tayo. Decreasing UO, high-grade fever, muscle aches. Ano pa? Ito na yung giveaway. Recent exposure to flood water. So, ano na yun? Gets na yan, ha? So, fever. Tapos, conjunctival suffusion. Tapos, icteria. Calf tenderness. Ako, sobrang bigay na yan. Sobrang giveaway na yan, okay? So, doon pa lang, mukha na siyang lepto, okay? Kasi, yun pa lang, exposure to flood water, tapos increasing crea, high-grade fever, muscle aches. So, very textbook case of leptospirosis, okay? So it's a zoonotic disease characterized with broad spectrum of clinical manifestations from asymptomatic infection to fulminant disease. So acute febrile illness of at least 2 days. Sa typhoid kanina, 38 degrees, more than 38 degrees for 5 days. Dito is at least 2 days. Leptospirosis, leptospirosis, 2 days. With at least 2 of the following. At least 2 days, leptospirosis, 2 days na acute febrile illness with at least 2 of the following. So syempre dapat may history siya na flooded, nagre-reside sa flooded area or highest exposure. Okay? So ito yung mga, so dito meron yung lahat ng patient natin. May suffusion, may ito, may ganyan. May jaundice din yung patient natin, may oliguria. Okay? Mataas yung creatinine. So, incubation period ng lepto is 2 to 28 days. In patients with mild disease, ito lang yung pwede na i-present, no? Pero in patients with severe disease, nagkakaroon na sila ng renal failure, mataas yung crea, decreasing UO, tulad ng patient natin. So, tapos may jaundice din yung patient natin, di ba? So, most likely yung patient natin ngayon ay severe leptospirosis na case. Okay? In terms of hemorrhage, the most common na site is yung pulmonary hemorrhage. Now, meron tayong tinatawag na Weil's disease or tinatawag din na severe leptospirosis. Weil's disease is characterized by jaundice, renal failure, and pulmonary hemorrhage. Okay? Hindi siya fever. Okay? Jaundice, renal failure, and hemorrhage. Or bleeding diathesis. Okay? So, jaundice, renal failure, bleeding diathesis, yun yung triad ng Weil's disease. Okay. In terms of diagnosis, it is not necessary to confirm the diagnosis or wait for results kasi matagal yung yung mga tests na ito. Kasi in terms of leptospirosis, tulad sa typhoid, meron din tayong direct and indirect detection methods. Sa direct detection methods, we have culture and isolation and PCR. Sa indirect detection methods, we have leptomat. Kung marinig yan sa clinics, leptomicroagglutination test, a 4-fold rise, or single titer of at least 1 to 1600. Yan yung magsabi na positive siya for lepto. And then, non-specific na like LAAS. Meron din tayong specific IgM na indirect detection method. Okay? So, hindi mo kailangan hintayin yan kasi medyo matagal yan, oras yan ang labas niya, lalo na yung culture and isolation. So, doon pa lang sa clinical na, natin na, hindi na tayo, di ba, kita nyo kanina, hindi na ako pumunta sa lab, di ko na discuss yun sa labs niya. Basta, doon pa lang sa clinical na, sa history niya pa lang, waiting flood waters, decreasing UO, muscle aches, calf tenderness, doon pa lang, leptospirosis pwede nang tawagin na ganun, okay? So, other lab findings, once lumabas yung ibang mas mabilis na laboratory, leukocytosis with thrombocytopenia, proteinuria, pyuria, high in granular casts, kasi nga nakaka-affect din siya sa kidneys, kaya siya nag-decrease yung UO, serum crea, tumataas, okay? So, dito, sa kitna na column, doon yung makikita may usual findings. Dito, these are the findings that are indicative of severe disease. Makikita niyo doon sa CPG natin ng leptoid sa Philippines. Ito yung mga indicative of severe disease, okay? Okay, other findings, pag mataas yung potassium, more than 4, so severe disease din yun, met acid, extensive alveolar infiltrates, and ECG. So, makikita nyo talaga multisystemic yung affectation ng leptospirosis. It can go as far as cause heart block, myocarditis, and polarization abnormalities, okay? So, in terms of treatment, we have para sa mild leptospirosis, and meron tayong for moderate or severe. So, actually, dalawa lang yung classification natin. Can either be mild lepto or moderate to severe lepto. So, sa mild lepto, the first line is doxycycline pa rin. Ang first line naman to moderate to severe leptospirosis is penicillin G. Pero mostly, nakikita nyo dyan sa clinics or sa wards, ang binibigyan natin is ceftriaxone. Okay, yun kasi yung readily available. Pero yung patient, pag yung patient is pregnant, bawal yung doxycycline sa mga patients mild lepto. If the patient is pregnant, we can give azithromycin. So the treatment is usually for 7 days, and usually pwede silang magkaroon ng tinatawag na Jari-Hertzheimer reaction. Hindi siya allergic reaction. Galing siya sa, it's from the, dahil nga nagbigay ka ng, for example, Penji, nagbigay ka ng Penji, namamatay yung mga spirochetes, yung mga leptospires. So dahil sa spirochete degeneration na yun, nag-react yung katawan, nagkaroon ng cytokine release, and the cytokine release leads to chest pain, fever, dyspnea, which is the typical Jari-Hertzheimer reaction. So it's an inflammatory process associated with treatment of leptospirosis with penicillin. So, in terms of prevention, the most effective, pag tinanong, the most effective is still avoidance of high risk exposure. Nagkamali na ako dyan sa exam kasi ang most effective na sinagot ko is doxycycline. So, hindi yun tama. The most effective na prevention for leptospirosis is avoidance of high risk exposure. Meron tayong dalawang klase, we have pre-exposure and post-exposure prophylaxis. Sa pre-exposure prophylaxis, it's not routinely recommended, but if you choose to do so, you can use doxycycline once weekly, start 1 to 2 days before the exposure. Pero, in terms of pre-exposure prophylaxis for pregnant patients, walang safe na pwedeng ibigay. Kasi nga, hindi ka pwedeng bigyan ng doxy sa mga pregnant and lactating. For natin silang i-categorize as kung sila ba ay low risk, moderate risk, or high risk. So kung single lang exposure, tapos ay wala naman siyang wounds or cuts or any open wound, no? Low exposure lang yun. And then kung may wounds or cuts, moderate risk ng leptospirosis. And then high risk kung continuous yung exposure. Okay? So kung low exposure, within 24 to 72 hours, dapat mabigyan mo na siya ng 200 mg ng single dose ng doxy. Kung naman, kung moderate risk naman, 24 to 72 hours of doxy din na 200 mg for 3 to 5 days. Kung ito single dose, ito ay 3 to 5 days. Okay? And then for continuous exposure, once weekly until end of exposure ng doxycycline na 200 mg. So lahat ng 200 mg, nag-iiba lang sila sa duration and kung ilang doses. Okay? So, tandaan niyo yung doxycycline na binibigyan natin, hindi niyo pwedeng gamitin if you are pregnant. Kasi it can cause permanent discoloration of the teeth later in life sa mga babies, sa ipapanganak ng baby. And hindi siya pwede sa mga lactating na mothers, sa mga nag-breastfeed na patients kasi it can pass into the breast milk. Okay? And can affect bone and teeth development sa pag-nurse ng baby. Hindi ka rin pwedeng bigyan ng doxy sa child na younger than 8 years old. Okay? Kasi nga, it can cause permanent yellowing or graying of the teeth and can affect the child's growth.